after the sinus rhythm was recovered, she was in electromechanical dissociation. So she was quickly transferred to the coronary unit where an ECMO was implanted. An emergent coronary angiography was performed, and to unload the left ventricle, intra-aortic balloon pump was also implanted in the patient. These are the images of the coronary angiography. As you can see, no obstructive lesions was observed. And well, after that, a transesophageal echocardiography was performed in the coronary care unit for further assessing the aortic valve. As you can see, the aortic area was 0.8. It was evaluated by planimetry in this case. This is a bicuspid aortic valve with a small raphe that was assessed in this technique. It wasn't identified in the previous thoracic echo. And it was also performed to further evaluate the mitral regurgitation. The patient had no organic lesion of the mitral valve. It was considered secondary ventricular mitral regurgitation due to the severe dilatation of the left ventricle. Some further images confirming the severe systolic dysfunction. And well, when we reached this point, the only possibility was to perform cardiac CT to evaluate the possibility of TAVI, and also to further confirm the diagnosis of severe aortic stenosis. The patient had an Agaston aortic valve score of 1,225 units of Agaston, which is slightly above the cutoff point for severe aortic stenosis in women. Well, in this case, the peritoneal stress echo was not an option because the patient was in a very critical situation. These are the measurements of the aortic annulus. She had a rather large annulus. Otherwise, well, the distances to the coronary arteries were acceptable. And well, anyway, the patient was discussed in heart team meeting because if it hadn't been the case of this critical situation, the first option would have been probably surgery. But due to the high risk of surgery, the surgeons were not keen to operate this patient. Transfemoral TAVI was preferred. She had good femoral accesses. So a balloon expandable TAVI was successfully implanted. And well, after TAVI implantation, the hemodynamic response was very good. In the following days, ECMO and intra-aortic balloon pump were removed. However, left ventricular systolic dysfunction persisted. During her hospital stay, she had several episodes of paroxysmal atrial fibrillation with rapid ventricular rate, which ceased after medical treatment. And she also had slow episodes of sustained ventricular tachycardia, but one of them required cardioversion. So finally, an ICD was implanted during her stay. Medical treatment could be up-titrated during the stay, and this is the list of her treatments upon discharge. She was anticoagulated due to the atrial fibrillation, and both losartan, bisoprolol, dapagliflozin, and eplerenone could be started. So these are some images from the follow-up transthoracic echo. This study was performed 4 months after discharge. As you can see, the size of the left ventricle had been reduced. And we also saw a great improvement in the left ventricular ejection fraction. Remember, she showed severe left systolic dysfunction on admission. It was 21% ejection fraction. Now she has 39%. The result of the TAVI was good. She showed mild aortic regurgitation, and the gradients were normal. Also, mitral regurgitation had reduced, and it was mild in the follow-up study. And well, even more important, the clinical follow-up was excellent at 6 months. The patient was tightly followed after discharge by the heart failure team. And the patient showed a good subjective state of health. She had a functional class 1-2, only dyspnea with important efforts. She was in sinus rhythm, and the NT-proBNP was really acceptable for this kind of patients. So, well, this is the case to sum up. Good clinical recovery after TAVI in a very complex case.
Thank you.
So again, I leave the floor to the discussants again.
Thank you so much, Esther. A fascinating case and brilliant presentation. Clearly, there was a lot of fairly scary moments during that course, but a wonderful outcome. Maybe I could turn to Bungsho Yu and just what's your comment on what could have happened here and whether there's any alternative strategies or what would you have done if things had gone in a slightly different direction?
I congratulations for successful treatment in the is a challenging patient. I think when you look at the echocardiography, there is no evidence of a concentric hypertrophy. It's just dilated of LV. If aortic stenosis is more challenging or more problem than the other fact, I think echocardiography was seemed to be the concentric hypertrophy. If patient progresses from the concentric hypertrophy to the eccentric hypertrophy in severe aortic stenosis, I think that the patient, a critically very, very severe patient with pulmonary congestion and low blood pressure. However, this patient is eccentric hypertrophy, only dilated LV with reduced ejection fraction. Aortic stenosis is, I'm not confirmed if a patient have a severe aortic stenosis because there is no evidence of dopamine stress test. And also cardiac CT is not essential to diagnosis aortic stenosis. But even the patient condition is urgent or surgical risk is very high in that time, it would be reasonable to proceed the TAVI based on the clinical judgment. However, therefore, once patient become clinically stable after initial ECMO or IVP or something, the additional evaluation would be necessary. Typically, the dopamine stress or MRI would be essential after initial stable condition. That is my suggestion.
Thank you very much. I mean, we've got quite a bit to discuss about the future management of such a patient, but there's something around the procedures that I might ask Raul to comment on, and that's a question from the audience of, would Impella have been a good alternative, less invasive and effective in unloading the ventricle? Your view on that?
Should I answer or Steph?
Yeah, just
Yes.
your comment.
I think that Impella in this case has the problem that having a severe aortic stenosis may be more problematic to use. And then after a cardiac arrest, so this patient didn't have only a cardiogenic shock but this patient had a cardiac arrest. I think in these cases in which the oxygenation is impaired, etc., I think the ECMO is more useful.
Thanks very much. Now, I'd like to turn to the longer-term management. Isabella, you made some comments on the previous case about, looking at the whole patient and evaluating things. This has been a spectacular outcome. Yeah. And you can imagine the patient and relatives might think, that's fine, I'm almost cured. How would you go about getting the patient information, explaining the situation, what structured follow-up? Because the patient's not going to be seeing these wonderful interventional cardiologists on a regular basis. It'll be the heart failure team.
Yes, I like this question. It's a brilliant question because sometimes we have to see the bigger picture, because we don't think about the basics, right? It's what you just said. You've done the wonderful interventions. We see here really great outcomes. And now we have some other issues. For example, the patient is on guideline medical therapy. There were, in one case, I've counted 6 medications. So now we have to work how the patient will adhere to medication, because we have a higher readmission rates even after wonderful procedures. And this is something that we have to work on, especially that the patient were both elderly. So we have to think if they have some cognitive impairment, we have to involve the family. And if we want to have the good outcomes, because the intervention itself, of course, we are very happy if everything goes well, but it's not only itself that is causing the good outcomes for the patient, because the patient is in our center care, right? We want them to survive also in the long term. So I think we have to work on the follow-ups and discharge plans, because when I was watching the case from Malta, I had already like a red flag that she said that the follow-up is after 45 days. So I think it's a long term. So I wonder, it depends also on the country, where the patient is treating during this period. Maybe the nursing team is doing the telephone follow-up. We do this in our institute, that the heart failure nurses are calling, and that we see that the patient is not, they are not coming to us every 3 months, because they are well taken care of. And I think it's all about the multidisciplinary team, that we have to see each other and work on better outcomes and on the adherence.
Okay, that's fascinating. Could I ask you, Sergio, this has been a great result.
Yes.
But clearly things can go wrong. What complications might you be very worried about that you want to...
During the follow-up?
Yes.
I think that this case, the result is very good. So the case is amazing. Maybe we don't expect any complication at short term. Maybe at long term, there is the probability of the ejection fraction is also worsening, because after TAVI there is a transient recovery of ejection fraction, but sometimes during a longer follow-up, there is a worsening of this ejection fraction. So this is important to perform, as Isabella said, that a close follow-up and to perform regular echoes to see the ejection fraction, and also to continue with the medical therapy.
And well, I was going to come to that point. What if the patient says, look, have I got heart failure anymore? Do I need to take all these tablets for the rest of my life?
We don't have strong evidence to support this, but if you follow the guidelines, they recommend to follow with the medical therapy even after recovery ejection fraction, because we have data with patients with dilated cardiomyopathy that those patients have a relapse in the worsening of heart failure. So it's important to continue with these drugs, but we don't have strong evidence to support this. But in clinical practice, I think that this is the thing that we do. But it is also true that those patients are very elderly patients with a lot of medication, and sometimes it's difficult to treat a patient over 80 or over 90 years with a lot of drugs. But I think that this is the optimal issue.
This is a great assist to introduce the mini lecture from Sergio on contemporary evidence-based medical therapy in those patients with aortic stenosis and reduced ejection fraction before and after TAVI.
Okay, so I'm going to talk about medical therapy in those patients with aortic stenosis and reduced ejection fraction, and I will focus on how to optimize medical therapy before and after TAVI, and also with a special interest on SGLT2 inhibitors. It is very important that in those patients the key aspect is to treat quickly the valve, to act quickly on the valve, but even after aortic stenosis correction, those patients still face a high risk of heart failure. This is the residual risk of heart failure. So in those patients, it's important to see over the valve and to consider the myocardial involvement. This is the classification of Professor Generox. And in the cases that Marta and Esther presented, they are clear stage 2 in both cases. So this is relevant to assess the probability of a good ventricular remodeling and the probability of recovery ejection fraction. And in this setting, last year it was presented a consensus document from the European Society of Cardiology that highlight the relevance of starting guideline-directed medical therapy early and start, if it is possible, before TAVI and continue after TAVI. However, in clinical practice, sometimes it's not possible to start these drugs, especially before TAVI, because physicians, we are very cautious in those patients with aortic stenosis, especially in patients with low blood pressure, in which starting beta blockers or RAS inhibitors is not easy. And also the evidence for the use of heart failure drugs in patients with aortic stenosis is also not strong, because in heart failure trials, patients with severe valvular heart disease or undergoing recent valvular intervention were excluded or underrepresented. So we need more evidence in this context to see about these drugs. For RAS inhibitors, we have a small randomized clinical trials in patients with aortic stenosis before aortic intervention, and those trials show that RAS inhibitors were associated with a higher regression of left ventricular hypertrophy in these patients with aortic stenosis. This was confirmed with ramipril or candesartan, so maybe this is a good option to start before the aortic valve intervention. And after TAVI, we have data of a small randomized trial, the RAS-TAVI, that randomized patients to ramipril versus placebo after TAVI, and in those patients, ramipril reduced the risk of HF in those patients, but there is not benefit in terms of mortality. We have also data for observational registries, like this big American registry with more than 20,000 of patients in which RAS inhibitors were associated with less readmission for HF, but also with a less all-cause mortality. For beta blockers, this is a very controversial issue because physicians are not very comfortable using these drugs before aortic stenosis correction, but we have data before TAVI with a small randomized trial with metoprolol versus placebo, and in this trial, metoprolol improved echocardiographic data and also metabolic data with the myocardial oxygen demand, but we don't have evidence in terms of clinical outcomes. And after TAVI, we have data of several registries, like Sweetheart Registry, in which RAS inhibitors were associated with less mortality in all patients after TAVI, but beta blockers reduced or were associated with less mortality only in the patients, in the group of patients with reduced ejection fraction. For mineralocorticoid receptor antagonist for MRA, we have a small trial with eplerenone before TAVI, and eplerenone did not improve echocardiographic parameters in those patients before aortic stenosis correction. And after TAVI, we have an observational registry from Japan, a small registry in which the investigators show that MRAs were not associated with a good prognosis in those patients, but this is for all patients with after TAVI, not only for patients with reduced ejection fraction. And we arrived to SGLT2 inhibitors. This is a very interesting drug, not only centered on the valve, if not also on the myocardial. We have data of an interesting study, the BioAS study, that showed that there is an overexpression of SGLT2-1 and SGLT2 receptors in patients with aortic stenosis, especially with the severity of the aortic stenosis increase. And there is an observational registry that shows that there is an association between SGLT2 inhibitor therapy with a slower progression of the aortic stenosis. So maybe this is a good option to start before aortic stenosis correction. And after TAVI, we can say that the only drug that show benefit in terms of reduction heart failure after TAVI are SGLT2 inhibitors. And this is based on our trial, the DAPA-TAVI trial that was presented and published in the in the New England Journal of Medicine last year. We randomized more than 1,000 patients to receive or not dapagliflozin after TAVI, and the result was a significant reduction in the composite endpoint of all-cause death or worsening heart failure in this population, and this happened for all patients regardless of left ventricular ejection fraction. So this is a mandatory drug to use in those patients after TAVI. And finally, we don't forget diuretic therapy. This is very important. In fact, most of patients after TAVI need the use of diuretic therapy, the use of furosemide. So this is very relevant to consider, especially if the patient have congestion or need diuretic before TAVI. So sometimes we put the TAVI and forget and stop the use of furosemide in those patients. So if the patient needs furosemide before TAVI, we can continue with this therapy, or maybe we can reduce the dose, but not stopping, because in the first month, in the first week after TAVI, there is an increased risk of heart failure. So a summary, in those patients with heart failure and severe aortic stenosis, the key question is to treat the aortic stenosis quickly, and then in all patients consider the therapy with SGLT2 inhibitors and RAS inhibitors, starting before TAVI if it is possible, and continue after TAVI. And also, we don't have strong evidence, but according with the heart failure trials, if the patient tolerates them, it is, I think that is useful to use MRA and beta blockers in those patients. For beta blockers, maybe it's more difficult for the risk of AV block even after TAVI. So, but I think that they are a very interesting drug. And we don't forget that those patients are very comorbidity patients with other diseases like ischemic heart disease or amyloidosis. So we have to treat also those pathologies. So in conclusion, I think that medical therapy in those patients should be focused not only on the valve, if not in the myocardial involvement. And in this setting, RAS inhibitors and SGLT2 inhibitors are very important drugs for the ventricular remodeling and for the recovery ejection fraction. Also, SGLT2 inhibitors can slow the progression of aortic stenosis. And if the patient tolerates them, beta blockers and MRA, I think that are very interesting drugs to start. And also, don't forget the use of furosemide, the diuretic therapy. Thanks.
Thank you. Excellent. So we've got some minutes for discussion, and I think it raises a very large number of issues. So we've got, it's a wonderful trial, congratulations for that, but we don't have adequate trials for all the other treatments.
Yes.
And this is a unique situation where someone's had bad heart failure, HFrEF, and then you've done something dramatic that sometimes improves ejection fraction. Do you carry on? Do you stop? And the data, apart from your study, are not adequate. The MRA potentially being harmful doesn't quite fit correctly in the patient selection. And I was also fascinated with the Danish follow-up showing that a lot of patients were getting better, but some patients were getting worse with increased usage, and there's a lot going on. So how do we pull that all together and come up with a management plan? Is it just watching and waiting, or is it proactively managing the patients going forward?
It's difficult because those patients are very elderly, and active treatment of those patients is difficult. But I think that we have to put all the drugs of heart failure in those patients, and maybe we need to support in the future with further studies. In this moment, there is an ongoing trial with beta blockers, because I think that it's very difficult to use this drug in clinical practice, because after TAVI, those patients have AV block, and we are worried to use beta blockers after TAVI, even in patients with reduced ejection fraction, and even knowing the results of the heart failure trials. But I think that we need evidence, and if it is possible, I think that we can use this drug, and waiting for the evidence that I hope in the next year we have more evidence to support the use of these drugs, but it's very difficult. Maybe the question is what happened then when the patient recovers ejection fraction. This is a very difficult question to answer, and maybe you can to individualize, maybe what is the situation of the patient, what is the follow-up of the patient, but this is, in this moment, it's impossible to say with strong evidence.
Is it all going to be follow-up echo, or is there a role for the nurse, Isabella?
Yeah, I think it's combined role. It's what we were talking the whole day today about the multidisciplinary teams. I think we have to collaborate, and we collaborate, it will be much better, because as you said, they are elderly patients, difficult to treat. We know that you have to treat them with caution, and we have to follow them. How are they doing right at home?
And also, those patients have another comorbidities that also condition the treatment of the patient. Maybe a lot of patients have malnutrition. That is a very relevant question that the nurse is very important to do the rehabilitation and also the rehabilitation of those patients after TAVI.
So from your lecture, one point is completely clear, that if we treat only the valve, we do only half of the job. So the point is now to treat the valve, but also to treat the cardiac damage. And to treat the cardiac damage, we need the medication.
Yes.
So my question is, when to start this medication? Is there any space to start, for example, aortic stenosis, SGLT2 inhibitors, when aortic stenosis is moderate, or when we already are suspicious of moderate to severe aortic stenosis? So before we start, better is for the patient.
In my opinion, and with the experience of my center, because we have a large waiting list, I think that when you have the diagnosis of severe aortic stenosis, you have to start medical therapy to prevent heart failure, and this medical therapy is very important to start SGLT2 inhibitors in this population, because those patients sometimes have heart failure waiting for the TAVI. So this is relevant. So if it is possible to start before TAVI and continue after TAVI. And I think that the problem of the waiting list in Spain is not only in my center, in other centers. So this is very relevant in those patients, because sometimes these patients have hospitalization waiting for the TAVI. So if you can to stop this or prevent this, it is very important to start therapy before.
So I'd like to thank everyone for the Improving Heart Failure function, putting it on, Pasquale and Raul for being the program producers, the two great cases from Marta and Esther, and wonderful discussions from Sergio, Isabella, Byung-Cho, and the great lecture you gave. I think we need to reflect on what we've heard, which is fascinating and very useful information. It's how to select patient with aortic stenosis and HFrEF. It's complicated, you know, how much myocardial damage is there, how much is reversible. To share experience of planning and performing the procedures, what to do first, how to manage things, and critically, I think at the end, the latest evidence for guideline-directed medical therapy, both pre and importantly, post-TAVI. It's a whole new area, and we are still short of clinical trial data, which is why that the study from you presented from New England Journal of Medicine last year was absolutely fascinating. So thank you very much, Paolo and everyone.
Okay, and so we can now leave introducing the next presenter, which is a clinical case from Frederick Randrume entitled Navigating a Challenging Cardiorenal Dilemma. So thank you, everybody, and see you soon.
Thank you.
Dear colleagues, I'm Frederick van Durm. I'm an interventional cardiologist with a keen interest in heart failure. I would like to thank the organizers for giving me the opportunity to present this case. I have no potential conflicts of interest. The case concerns a 17-year-old gentleman with classical risk factors who has a long-standing history of atrial fibrillation, implantation of a VVI pacemaker in 2021. Subsequently, he developed heart failure symptoms, which event in the end led to systemic congestion. His ejection fraction went down to 35% and his GFR dropped to 35. Eventually, he was admitted to the nephrology ward because of evolving edema, ascites, and bilateral pleural effusions. On the nephrology ward, he received intravenous diuretics, and this led to improvement of his weight. There was a weight loss of 17 kilograms, where his eGFR stayed rather stable at a value of 28 milliliters per kilogram. An echocardiography was performed, which showed an LV ejection fraction of 20%, dilatation of both right heart chambers, and more than moderate regurgitation of both atrioventricular valves. There was clear systemic and hepatic congestion. So when taking a step back and having a broader view of the problem, we see a patient with worsening cardiorenal syndrome, biventricular failure, with a dismal prognosis. However, the patient felt a bit better and he wanted to go home and refused to participate in further diagnostic procedures. He was seen back 2 weeks later. Still, there was edema of the lower limbs and ascites. The weight even had gone up a little bit, and his GFR dropped further down to 15 milliliters per minute per 1.73 square meters. So the nephrologist wanted to start dialysis. The patient declined. However, the cardiologist thought there is still some room for decongestion, as there was still signs of severe hepatic congestion. According to portal vein signal, there was even RV overload. To consolidate this approach, a right heart catheterization was done, which confirmed the presence of high right heart filling pressures, in addition to postcapillary pulmonary hypertension. But however, luckily, cardiac output was still preserved, and the right-sided prognostic indices were not that bad. So the patient was admitted on the CCU, where we started high-dose bumetanide in continuous infusion in addition to acetazolamide. This led to a weight loss of more than 20 kilograms. In addition, a second paracentesis was done, where 8 liters of ascites were removed. Blood pressure got a bit better, eGFR as well, and so we were able to start and up-titrate the 4 pillars of heart failure with reduced ejection fraction. A myocardial perfusion scan was suggestive of an ischemic etiology. However, there were still signs of congestion. There was no more RV overload according to parasternal short axis. However, portal vein and appreciation of the vena cava still were suggestive of ongoing congestion. A second right heart catheterization revealed, however, a complete different picture, where right heart pressures were completely normalized. There was still postcapillary pulmonary hypertension with a huge V wave, probably due to stiff left atrium, but PCW now was only 18 millimeters of mercury. So some additional diuretic therapy was given. However, overdiuresis was avoided. Coronary angiography was performed and confirmed the suspicion of severe triple vessel disease, which was not amenable to percutaneous coronary intervention. As the prognostic right heart parameters were not bad at all, a decision was made in the heart team to perform surgery. CABG was performed, repair of both mitral and tricuspid valves, and a CRT device was implanted as there was total AV block and to get rid of the dysynchrony. 1 month later, patient got better, did well. We could further uptitrate our 4 pillars, and 2 years later, the patient didn't experience any episodes of decompensated heart failure. So for take-home messages, we can conclude that when there's a combination of biventricular heart failure, atrial fibrillation, and more than moderate AV valve regurgitation, it's sometimes difficult to quantify true filling pressures, to delineate the endpoint of IV diuretic therapy, and the right heart catheterization can help us to unravel the relative contribution of congestion as opposed to low output in the cardiorenal syndrome, and to see if additional diuresis is necessary. Sometimes a second right heart catheterization can even more refine the correct therapy and also help us to delineate the true risk of acute right heart failure when cardiac surgery is needed. Here I want to end, and I want to thank you for your attention.
Hello, and welcome to this session on decision at the edge, from drug escalation to CIAD implantation in atypical HFrEF. It's a pleasure to be joined as a co-chair by Professor Christophe Leclerc, and we look forward to a very entertaining session.
Thank you very much, Giuseppe. So we have a very famous faculty with us. Gianluigi Savarese, Jose Merino. Online we have Aaron Berry and also Carsten Israel. And now we will start this session with a very interesting clinical case prepared by Aaron Berry. So Aaron, the floor is yours.
Thank you very much, Christophe. Hello, everybody. So I don't know if you can see my slides.
Yes.
Yep.
Okay, there we are. All right, so I see the session objectives. Maybe we could move on. There we go. So this is a case. These are my disclosures. And this is a case of a 62-year-old gentleman who was admitted for syncope. It was pretty sudden onset without many prodromes. He has a history of non-ischemic cardiomyopathy with 40% ejection fraction, class 2 heart failure, and he's been in persistent atrial fibrillation since 2 years. The medications you see listed there, they just about have every single drug that he needs, probably with also suboptimal doses, but the problem is that he also has relatively low blood pressure. So the admission, this is his physical status, blood pressure 100/50, nothing really very remarkable there. His echo showed 40% ejection fraction, dilated left atrium, 28 square centimeters, and mild mitral regurgitation. All the lab tests were within normal limits. So this is the ECG, and you can note that the patient has atrial fibrillation between 60 and about 70, 80 beats per minute. The QRS is somewhat enlarged at 148 milliseconds. I'll let you look at the morphology and maybe decide for yourself if you think that this is a left bundle branch block or a non-specific ventricular conduction delay. So an MRI was performed and showed some late gadolinium enhancement in the mid-septum and also in the lateral wall. And according to the latest ESC guidelines for risk stratification for sudden death, what you can see in the red dotted framed recommendation at the bottom is that patients with dilated cardiomyopathy, non-ischemic dilated cardiomyopathy, who have unexplained syncope, then may be considered for an EP study with a class 2A indication. So this is exactly what we did in this patient. And you can see with the pacing protocol, we induced monomorphic sustained VT. The patient was symptomatic, and we performed actually overdrive and stopped this VT. So the questions here are, what would be your next step? Would you just treat with antiarrhythmic drugs? Would you perform VT ablation? Would you implant an ICD? Or would you implant an ICD with either biventricular pacing or conduction system pacing? So I think you can start voting on this.
Now,
and Christophe, while they're voting.
For the vote, so we expect to have your answer within the 30 seconds with a different strategy of treatment in this patient with a borderline high QRS and low ejection fraction. So now we can take the result, and it's pretty split between the different items. Some of you are giving antiarrhythmic drug in this patient, and few are performing VT ablation, and the majority is ICD with or without CRP and CST. So continue, please, Aaron.
Okay. Now, probably.
Yeah.
I think I'll let Jose maybe.
Yes, yes. Maybe we should start discussing what to do with this patient. And maybe I can share what we will do in our center, for example. So maybe we can change to my presentation. And
I think we have a time for discussion about the risk stratification, because thank you, Aaron, for providing a very interesting cases, because as was mentioned, we had borderline left ventricular ejection fraction, 40%, and the curious duration was 148 milliseconds, so very close to 150, but not so on. So in this type of patients, especially the problem is the stratification of the sudden death or VT ablation. So a question first for you, Aaron. You mentioned that your EP study was performed. Is it your common practice in patients with non-ischemic cardiomyopathy?
Well, traditionally, EP studies were performed really in patients with ischemic cardiomyopathy since many, many years, since the MADIT years. But we know that it can also be performed for non-ischemic cardiomyopathy for risk stratification and also for the workup of syncope. And this is exactly what was performed in this patient because he was considered at relatively high risk for sudden death, given also the results of the MRI. And I think there's a lot also in imaging for risk stratification with mid-septal fibrosis and lateral wall fibrosis. So we know in these patients also that the substrate is there for ventricular arrhythmias. So indeed, in these patients where you're not completely at ease, they're presented with syncope that really looks like arrhythmic syncope. I think you need to go forward and do some extra testing like we did with EP study.
John, do you want to comment about this patient?
Haran, I think you highlighted a very important fact, which is, first of all, trying to phenotype at our best these patients who are borderline in terms of so many different indications here. So I really appreciate the value you are giving to the MRI here. I think it's extremely important that this patient received an MRI for actually the assessment of fibrosis. So my first question to you is like, would you consider to perform an MRI in such a patient in general? So even if you already know that the patient has not ischemic cardiomyopathy, would you proceed in any case to perform an MRI in general in these patients?
Well, yes, indeed, because first of all, it can give you, I think, an etiological perspective of what type of underlying disease we have. Number one. Number two, for the risk stratification, as we just mentioned. And number three, if this patient needs an ICD and ends up with an ICD, you're better off having the MRI study performed before the device is in, because the leads and the generator will yield artifacts which make further MRI study less valuable. And also, in one of the options we had was VT ablation. There are software out there that help us to better understand where the substrate lies, where the channels are, and can help the electrophysiologist guide the ablation procedure. So for all of these reasons, I think it's very important to perform the MRI as part of the diagnostic workup. And relatively early.
So here you have also a patient with a borderline indication for an ICD. I think we really need to understand much more. We have a patient who is not really tolerant to GDMT. Many colleagues may be there actually trying to wait some time for further up-titrate the treatment. I think a good assessment, a characterization of the myocardium in these patients and the assessment of the fibrosis actually very much helps also to understand what it will be in the future in terms of implanting or not a defibrillator, beyond, of course, the discussion we are having regarding the arrhythmias this patient have.
And maybe I can bring in Karsten now. Now, of course, we have very strict cutoff points, but it's nothing, it's black and white. We have shades of green, and especially if you think of these patients, if you were a woman, would you would have gone for a CRT-D straight away.
Yeah, that's a very good point. I think Haran made a great case where everything is borderline. Ejection fraction, QRS duration, type of bundle branch block, or maybe no bundle branch block, but rather indeterminate conduction delay. And as you say, the gender needs to be also taken into account, because a QRS of 148 in a small female is something else than a QRS of 148 in a very tall male. So maybe my question to Haran would be, of course, this is a patient where we have to think, we need to know the guidelines, have to think and individualize our approach. How important for you is the QRS duration and QRS morphology in deciding CRT or CSP or just a simple ICD?
Yeah, I think you raise an important point here. Gender does matter. In general, women do have smaller hearts, even for the same body surface area compared to men. And we know that the QRS duration is impacted by, the heart size. Therefore, as you mentioned, the QRS duration in men and women may not have the same cutoffs. In the guidelines, there's no distinction which is made. Simply, I would say, in the interest of also usability, because these algorithms are already quite complicated as they are, and if you add an extra stratum with the gender, it just makes it very, very complicated. So in these cases, the QRS duration is important. I think there's no question, but so is morphology. So in a patient with a typical left bundle branch block, and if the QRS is really wide, over 150 milliseconds, the evidence really is for biventricular pacing. We have decades of research and tens of thousands of patients in randomized studies that shows that BiV pacing is effective. So I think we can't neglect that. And BiV pacing would be my choice. In a QRS duration that's less wide, such as in this patient, and also a morphology that is less typical of left bundle branch block, then I think the options are open. And then it's really a question of individualizing what sort of treatment one is delivering, be it CSP or BiV pacing.
Yeah, you raise a very important point, Haran, that as you know, there is a intra and intervariability when you try to measure the QRS duration. And I'm sure that if we ask the panelists to measure the QRS duration, we will find some of them above 150 and some of them below 150. And especially sometimes you look at different derivation and you can find something different. So have you an advice for our audience how to measure the QRS duration?
Well, I always look at the automatic measure. I think overall it works pretty well. You're right. You look at the lead which has the broadest QRS, but you have to have also a pretty good idea where the QRS starts and where it ends. The paper speed is also important. I think in many countries it's 25 millimeters per second, and that sort of limits the resolution. Where Carsten works in Germany, they have 50 millimeters per second, and I think that's better suited actually for measuring the QRS duration. And you're perfectly right. And there was one study years ago, I remember, published in Europace, where there was an inter and intra-observer variability being measured and looking at different paper speeds. And for sure, at 25 milliseconds, we're less reproducible than at 50. But the reproducibility is imperfect as is. So I combine looking at the automated measure, and this was actually an automated measure because, of course, at 148 milliseconds, you're not able to do that yourself, but just by looking at the QRS. This was actually an automated measure. But I also do check, does this sort of eyeball, does this measure correspond with what I measure manually?
Jose, do you have a comment about this topic?
Yes, in fact, we published some years ago about this specific topic. What we did is measure the QRS complex with the EP recording system at 100 millimeters per second with electronic calipers and all leads simultaneously to avoid this problem of onset sooner in one lead than in the other, and compare it with 4 different measurements from different colleagues. and we found that the correlation between the different observers was relatively poor, and also with the EP recording system, with differences up to 20 milliseconds. So I fully agree with Haran's comment that in general you should rely more in the automatic measurement of the machine, and rather than measure yourself on the paper.
Okay,
and maybe if I can comment in between, I think we are in the 21st century and even quite advanced. All our ECGs nowadays are electronically on the screen. So what we usually do, we like 25 millimeters because every notch is better visible, but then we blow it up 30 times, so at 3000% resolution or size, which is 30 times magnification. You can in fact measure manually every 2 milliseconds. So if this is half or a quarter or an eighth of a millimeter, and that would be my advice in all these cases where it's not so clear, try to find a good QRS and then blow it up on your screen and then check it. And I would also say, yes, Haran, automatic measurements are usually very, very precise and valid. But sometimes every now and then, for example, in atrial fibrillation, the automatic algorithm is not so reliable.
Okay, so now I think it's time to move to Professor Merino, and that will tell us how would you treat this patient.
Thank you, Giuseppe. So I was asked to give a summary of what we should do in this case, or what we do in this kind of patients. So these are my disclosures. So what are the clinical questions in this, let's say, unclear situation? It's non-ischemic and non-clear left bundle branch block, so unclear, to be honest. So for me, there are three main questions. One is ICD, yes or not. Number two, CRT, yes or not. And finally, if we decide to implant a CRT device, whether we should implant a biventricular conventional device or a conduction system patient one. So let's start with the first one, ICD, yes or not. We know from different studies and meta-analysis that the ICD provides prognostic benefits in this situation in non-ischemic patients. It's true that some later trials question the benefit of ICD in non-ischemic patients with, for example, Danish trial. However, in this trial, there were also sub-analyses suggesting that still there was a benefit, especially in younger patients, like the patient presented by Professor Burri. So this is somewhat reflected in the last version of the guidelines. And in the last version of the guidelines, a patient with non-ischemic dilated cardiomyopathy with ejection fraction that is not clearly below 35, but still below 50, and if the patient has additional risk factors, 2 of them, you should consider strongly to implant a device. And this was the situation of the patient, syncope and inducible VT. So probably most of us will implant an ICD in this patient. The second question is CRT, yes or not? And we know from seminal trials that CRT provides additional benefits to drugs in terms of prognostic benefits. This is the classical iHF trial, which demonstrated benefits in primary endpoint, but also in mortality of cardiac resynchronization compared to just medical therapy alone. So what the guidelines say to CRT or not to CRT in this patient, what is crucial is to differentiate between left bundle branch block, that in this case, for example, because the patient has less than 150 milliseconds QRS duration, will be a class 2A indication. But this is different if we decide that the patient has no left bundle branch QRS complex morphology, in which the level of recommendation is downgraded to 2B. So this is the ECG of the patient, and we need to decide whether this is a classical left bundle branch block morphology or not. And the guidelines also provide in the supplementary document some criteria. And in this particular patient, some criteria were fulfilled, but no others. So in general, we should call this not a classical left bundle branch block pattern, but a non-specific intraventricular conduction delay 1. So in that situation, indication of CRT is less clear and is a class 2B indication. To make things worse, the patient is an atrial fibrillation. And in guidelines require a class at least 3 or 4 to consider CRT strong enough to be indicated. And therefore, if we summarize the situation in this patient, we have to admit that there are some uncertainties about CRT. There is a non-left bundle branch block pattern. Ejection fraction is not below 35. In fact, it was 40, and atrial fibrillation. However, at the same time, CID implantation is already indicated, so not adding a CRT feature to the device is probably something that may us uncomfortable. And we should also consider alternatives to modify the uncertainties. Are any way to modify them? Yes, maybe we should also give some thoughts about atrial fibrillation. And we know that atrial fibrillation and heart failure interact strongly. And in fact, one favors the other, and the other favors the one. So it's atrial fibrillation begets heart failure, and heart failure begets atrial fibrillation. And we know from some trials that similar to this patient, a patient with a ICD indication and somewhat depressed ejection fraction, that FE ablation provides additional prognostic benefits in terms of death and hospitalization compared to medical therapy alone. In fact, this is being studied by our group, by a trial that is presently conducted. Haran Barry is the PI, and is trying to answer the question whether in heart failure patients with atrial fibrillation, it would be better to go for a FE ablation or AV nodal ablation with conduction system pacing. So finally, if we have decided to go for a CRT mode, we have to decide whether biventricular pacing or conduction system pacing, and for that we need to go to the last ESC consensus on this topic. And in this particular situation, with an ejection fraction between 35 and 50, you can choose both biventricular or conduction system pacing. The situation is unclear. And even if you perform AV nodal ablation, the same. So final choice from my side, CRTD, either with biventricular pacing or CSP, with an atrial electrode plus AF ablation. Thank you.
Thank you very much, Rode, for sharing this interesting question about this difficult case, because it's, as you mentioned, we are totally in the gray zone. Just want to come back first at your talk about AFib ablation in heart failure, because we have the CASEL-AF and also the CASEL-HTX trial. We did show that AFib ablation dramatically changed the outcome of the patients. If I remember well, it was conducted in patients with paroxysmal and persistent ablation, and this patient had a persistent ablation since 2 years with a moderate dilated left atrium. So for you, it's clear that there is a role for AFib ablation in this type of patients.
Yeah, you are right that in patients with paroxysmal atrial fibrillation, you may expect better results with ablation than in patients with persistent. But it's true that at the beginning we were a little bit reluctant to refer patients with heart failure for ablation because we were expecting worse results. But the truth is that it's the opposite in terms of maybe you have worse results in rhythm control, but in terms of prognostic benefits, it's clear from different trials that ablation provides a significant prognostic benefit in this particular population. So I think that AFib ablation is true that it implies some cost implications, but in general, the risk associated with an ablation is not that high, and the potential benefits are enormous. So I will consider it for sure.
And also we have to stress the fact that in this patient with a low ejection fraction, we are limited in terms of antiarrhythmic drugs. And usually you may have amiodarone, or in some countries, dronedarone. Just a question for Carsten as well. Do you share the view of Jose about AFib ablation in heart failure population?
Yeah, thank you very much. That was a great discussion because you raised all the uncertainties and you kind of pinpointed that we have guidelines, but you know, in the individual case, it's difficult if they apply yes or no. And it sounds very much like this is a class 2BB indication, level of evidence C, and still it may make a lot of sense to think about all these possibilities that we have at this point in time. Now, I absolutely agree, and Jose was putting it very nicely, that when we started AF ablation, it was always a little bit the most risky ablation that we have, can take hours, can cause a stroke, doesn't work in the end, and particularly if the left atrium is big, then it may be very difficult to get a beautiful line and a beautiful disconnection of the veins. And so we were very reluctant to use it in heart failure patients, only to find out in the end that it may very well be that heart failure patients are the one group that benefits the most. And I think that makes a lot of sense. If you are in a severe cardiac condition, then to get rid of this irregular and usually too fast rhythm is much more important than if you are in a stable cardiac condition where ablation is easier, but you know, you can also do without it. So I think Jose is absolutely right that AF ablation in this type of patient should always be given a thought, and we should not be so hesitant as we used to be 20 years ago to use it in patients with severe heart disease and ejection fraction like 40, 35 or less.
Yes, look, I'll take a different perspective, and I know I'm in the cage of lions because I approach it more clinically. But in patients like this, where you have a heart rate that is below 70, below 80, where patients have hypotension with beta blockers. Now, we have shown that by the meta-analysis of all the trials in with beta blockade, there's no benefit of beta blockers in heart failure patients with atrial fibrillation. Do you think that discontinuing the beta blockers and eventually use digoxin can be an option? Or if you continue this patient, then given that it has a lower heart rate, then there is an indication before to be more aggressive, given the fact that in the sweet spot for heart rate in these patients should be between 80 and 110 beats per minute. Do you think that that makes any sense in terms of medically treat these patients?
I think that, okay, that you have more knowledge about drugs, Giuseppe, so, than me, but I think that it's a young patient. So for me, digoxin is getting a more, let's say, or the digoxin is getting more popularity, especially after recent trials. So I think that is something that you should consider. It's true that it's a young patient, so with some adrenergic consideration in young patients. So it's something that you should consider. But I think that the fact that the beta blockers are not working with atrial fibrillation makes the indication for ablation even stronger for that reason, because then you get let's say you get rid of the problem of CRT implantation in an FE patient, and in addition, the potential benefit of beta blockers.
And I mean, in this patient, another problem is indeed, as you are highlighting, the tolerability to pharmacological treatments. And I think here a device by acting at different levels might be also quite important to try also to further push for improving pharmacological treatment. Indeed, here, if we consider a CRT, for example, we know several studies have been showing that it might be an enabling role for improving the use of pharmacotherapy after the implantation. So I think here we have one further, let's say, heart failure-driven reason for considering a CRT in this patient. Then I have a question for all of you. So we actually we have quite recently shown in real-world data, but still very large cohort and so on, that actually CRT is of value in terms of probably lower risk of mortality and morbidity, even in patients with atrial fibrillation. Of course, this is a real-world study, so patients who had atrial fibrillation and received the CRT had particular features, but I would very much love to hear your opinion as experts regarding this aspect.
Aaron, do you want to start to answer the question?
Well, I'll give it back to you, Christoph. You know, you're one of the popes of IV pacing, so go ahead.
No, thank you. No, I think that it's a very good question because we have a lot of evidence for CRT in patients with sinus rhythm. But I must admit that for patients with atrial fibrillation, we have a less large number trials. I think also the advantage of AV node ablation in this case of patient is that patient will remain in atrial fibrillation. But when you have a patient with atrial fibrillation, we have to keep in mind that the irregularity of the rhythm may have a significant impact on the hemodynamics of the patients, especially if patient with very low ejection fraction. So I think that by treating, as proposed by Rose, with AFib ablation, you restore atrial kick. Also, you correct irregularity. So I think that it's important. And coming back to your question about CRT, I think that CRT is efficient in patients with atrial fibrillation unless you provide a complete biventricular capture. It's 100% of the time. And we did show that even if you go to 95%, you decrease the impact of CRT as compared to 100%. So during the follow-up, you have to be very cautious about the IV pacing rate and to do any action with drugs for more aggressive treatment like AV node ablation, or perhaps to consider as well after AFib ablation as it was done by Rose in this case.
Thank you.
So I think that AFib ablation is a good population for CRT as well. Okay, so maybe we can move. There is a comment from Carsten.
Just, I would like to comment. I think what we pointed out very nicely here is that this patient has a number of arguments to implant an ICD. Number one, he had a syncope. Number two, he had mid-wall fibrosis, which is a very important risk marker in non-ischemic cardiomyopathy. Number three, he was inducible. So I think that there are lots of good arguments to implant an ICD in this patient. Now, if we implant a device anyway, I'm always very, very biased to not only do something prognostically, but also try to improve his hemodynamics. AF, yes or no? So I would, and if I see that this guy cannot take his recommended drugs due to hypotension, I would always be very biased to try resynchronization in any form to get his blood pressure up again and make him more tolerant to higher drug doses. And that would be an important argument for me if device then think, if possible, about resynchronization at the same time.
Carsten, I completely agree with you. That's a very important point. And, you know, that's really, as I was also highlighting, using a device to try to further, to facilitate better use of pharmacotherapy. You were describing very well the risk of these patients, and you guys performed a very well risk stratification in this patient. My question is, do you think there is further role for a genetic testing in this patient? Do you think that you have already enough argument for a device implantation, or you would also like to see the genetics in this patient?
That's a great point, honestly. And we live in a complex world, and we make it even more complex. I would say yes, in search for arguments how to best treat this patient, it is nice to have imaging, echo MRI on one side. It is very important still today to have also electrophysiologic risk markers, anything non-invasive, in this specific case, even invasive. And number three, if we have the underlying genetics and the ESC guidelines on genetic cardiomyopathies outline this very, very nicely. We have another argument to know what is most likely the further course of this patient without optimal treatment. Is he at risk for deterioration of hemodynamics or arrhythmias? And that would give us another specific argument. And I agree totally with what Haran said about gender and cure restoration. In guidelines, we should not make it too complex, because otherwise they are not usable at the bedside and they are not really big fun. So there are lots of arguments that are difficult to implement in guidelines. But as you say, to have it as a clinician at your hand, I think it's very useful.
Yeah, and I have a quick question to Aaron, maybe. I agree with this patient with syncope. I understand there's an inducible VT, but we base the syncope and we think that that syncope is due to arrhythmias. Now, what about if in this patient who has low blood pressure, that was a different type of syncope? Now, would you do a TIL test just to exclude, or you could just go for, I mean, I understand that there is a clear inducible VT, but would you do any additional test to understand whether that syncope was real arrhythmic?
Well, I mean, there's no way of proving that it is arrhythmic or that it was not arrhythmic. The only way was, would be to have a concomitant rhythm monitoring. I don't know, with the implantable loop recorder or something, and we don't have that. In this patient, I wouldn't delay things further and just add on exams, because the patient has a clear indication for an ICD. You need to place in the ICD. If the patient may have also in the future syncope due to low blood pressure, then we'll have to deal with that at a later stage. And then we will know that it's not in that specific circumstance due to an arrhythmia. And we'll take it one step at a time. But as we are today, I think the patient, as Carsten mentioned, has a very clear indication for an ICD.
Excellent. Now, I think it's time to move on to the case resolution. So go back to you, Haran.
Yep. Okay. So if you can show the slides, there we go. So I'll just let you know how we resolve this case. Again, this is the ECG, and yeah, so for us, this is non-specific interventional conduction delay, as was already discussed by Jose. And as you can notice, the AFib is not very fast, and you have to anticipate what's going to happen with drugs. We're probably going to try to increase beta blockers if possible, just for the sudden death management. Maybe this patient may have amiodarone in the future for ventricular arrhythmias. So you can anticipate that the conduction, the AV conduction, is going to get slower. And then the patient will be paced more frequently. And then it's better to have some sort of physiological pacing, be it by V pacing or conduction system pacing, right? So in this instance, we started off actually with by V pacing. Let me just try and I can't move the slide forward. I don't know, Christoph, if on your side, there we are. Okay, so this is with by V pacing. You can see the right bundle branch block pattern in V1, positive QRS, negative in lead Roman 1. This is by V pacing, but honestly, the QRS does not look very, very physiological. It's quite notched as well. So in this instance, what we did was that we went also for his bundle pacing. This was a patient done some years ago. And you can see there's actually a transition in the QRS morphology with reduction in pacing output. And that proves that we've got actually His bundle capture. And the first three QRS complexes that you see are with His bundle capture. And again, the QRS is not normal. It's relatively broad and so not really satisfactory either. So if we go back to our consensus document, in these instances where you have a wide non-physiological looking QRS complex with either BiV pacing or conduction system pacing, you can do what's known as hot or LOT CRT, His optimized CRT or left bundle branch optimized CRT. And this is actually what we did here. We combined the His bundle pacing with BiV pacing. So the device was actually a CRT-D device, and we placed the His bundle lead in the atrial port. And we got a QRS that looks a lot more physiological. Our initial intent was to indeed place an atrial lead because we know that patients who do have BiV pacing or conduction system pacing can actually revert spontaneously to sinus rhythm. But in this instance, we rather chose to go for the hot CRT because the AFib was long-standing persistent since 2 years. The left atrium was dilated. It wasn't severely dilated, but dilated nonetheless. And we thought that the likelihood of reverting to sinus rhythm was not very high. So this is what hot and LOT CRT looks like. You have a combination of BiV pacing or left ventricular pacing via the coronary sinus lead and conduction system pacing, either His or left bundle branch area. And the patient was followed up at a year, and the symptoms were stable. The beta blockers were increased. We also could increase the sacubitril valsartan. The patient had no recurrence of syncope during that time frame. His heart failure symptoms remained stable. He wasn't admitted for heart failure. Device interrogation showed that the percentage of ventricular pacing was 76%. Indeed, it's not negligible because of the increase in the beta blocker doses. And there were no ventricular arrhythmias over that follow-up duration. Right, so that's the follow-up for this case.
Thank you very much, Arando, for this very challenging case. And as we can see that there is no strict agreement between you and Rosé. Rosé was a little bit more aggressive for AFib ablation. And now just a comment you did during the case resolution presentation, Aran. You mentioned amiodarone in your talk. I must say that personally, I am very reluctant to use amiodarone in young patients because I am living close to the sea, and perhaps it's the reason why, but we had in the past a lot of complication with amiodarone, especially if you have to prescribe the amiodarone for a long term and with hyperthyroidism or often or sometimes pulmonary fibrosis. So personally, I try to, in my clinical practice, to avoid amiodarone on the long term in young patients. So I think it's something we have to keep in mind due to the side effect. I have a question for all of you. Sometimes we can consider to make an electrical cardioversion just to see if we have a recurrence of atrial fibrillation very quickly or not. And this can be an argument, perhaps, for some physician to go for AFib ablation. Did you consider this, Aran, just to make a cardioversion, just to see if the sinus rhythm will be maintained or not for this patient?
Yeah, I think it's a very clinical strategy to do this, and I actually do this sometimes in patients who are referred to me for long-standing AFib ablation, in whom I'm not extremely. There are several markers that show that maybe this patient, it won't be successful. You perform an electrical cardioversion and you see how that goes. In this patient, we didn't. We could have, but you sort of deal with one thing at a time. And this patient wasn't extremely symptomatic from his atrial fibrillation either. And you also have to look really at the long-term picture. So you can perform electrical cardioversion and see how long that holds for. And the longer that holds for, the more inclined I am to go ahead with AFib ablation. But in this instance, we really had to deal with the matter. The patient came in with a syncope, and no, that was really the main issue that we had to deal with.
Okay. And maybe a question to you all. I mean, given the results of the DIGIT trial, I mean, would you consider just to increase the amount, the degree of ventricular pacing, that add digoxin, even small doses, to this patient?
Yes, maybe I can start and then share the comment. I think that, this is something that I have learned from my heart failure colleagues, that you should not focus in black and white, so CRT responder or not responder, so there is a gray zone. So in this patient, it was apparently a response because the patient improved ejection fraction, but probably we need to be ambitious and trying to increase this percentage of CRT pacing. And one way to go, and probably is the first step, will be to use drugs, as you are suggesting, especially with new evidences supporting the use of digitalis, but I am looking forward to your comments.
Yeah. No, I understand your point, which is mainly related to the meta-analysis and the data showing that there is no prognostic role of beta blockers, whether there is atrial fibrillation. But it's for sure true, but I think here the indication is not for heart failure, but rather for improved biventricular stimulation, and also a little bit as antiarrhythmic, for given that this patient has actually a high risk of getting arrhythmias. So actually, in my opinion, I mean, by considering also pill burden and many other factors, here whether with the beta blocker we are fine with achieving our goal, I will accept that, honestly speaking.
I mean, I meant use the beta blockers and digoxin together.
Indeed. Yeah, but you might add one pill more. Here, heart rate was overall, I think, well controlled. The percentage of biventricular stimulation was good. So here, I think we might be even happy with the therapy, which, as it was said.
I think it would be interesting to ask Carson, what would you do?
Yeah, thank you very much for this question.
Different strategy. What is yours?
Yeah, in terms of beta blocker and digitalis, we used these two together for decades with the idea that beta blockers work best during exercise and digitalis works best at rest. And so we have all covered. And I think in patients where we want to increase the percentage of ventricular pacing, this works quite nice, and we can increase the percentage. And at the same time, with an ICD, we are safe from the side effects. Of course, these experiences stem from a time where the dose of digoxin and also digitoxin were higher than what we use today. So there were patients without an ICD who died from digitalis because of ventricular fibrillation. And that's one of the things that I would also still bear in mind, because today, yes, there is a revival of digitalis, but I would say it is not so innocent. And altogether, I liked also the concept of cardioversion very much that you put forward. Mostly because I want to see if the patient feels dramatically better in sinus rhythm or not. Because frequently we have to decide, do we want to get more and more invasive second or third ablation for atrial fibrillation? And if so, we need to have a good reason. And if the patient is dramatically better in sinus rhythm, and sometimes this does happen, then I would be inclined to increase our invasiveness. But if the patient says, well, honestly, I didn't feel a difference, then I would stop ablation earlier.
Okay, thank you. Aaron, as you know, and there is a huge debate at this time, CSP or BiV pacing, and you very elegantly answer the question by combining the two strategies, which is very neutral. But I think it's in your presentation, you have a very important message that CSP and BiV are not opponents, but they can be combined together. And I think that is something that the electrophysiology should consider. If your result is not acceptable or borderline with one of the two strategies, you can add the other one. So I think it's a very important message. Is it something you do frequently, Carsten, in your practice? Because you are a device specialist as well.
Yeah. Well, thank you, Christophe, very much for this question, because I would say, yes, this is in many patients a very important and good solution. And you and me both, we have been big fans of biventricular pacing for decades, because we have seen the sometimes dramatic improvements in patients just by improving synchronicity. However, we have also seen patients where it does not work. And one of the problems, in fact, is that we have epicardial pacing, and in very sick left ventricles, this may not get from the epicardium to the endocardium quick enough to resynchronize completely and nicely. So I think to combine epicardial pacing with conduction system pacing is a beautiful way to get patients with a pure left bundle branch block better. But if they have additionally intraventricular conduction problems, then we can have all both in combination to get the best we can from our devices. So we use this quite a lot. And particularly if a patient has a traditional indication for biventricular pacing, that means left bundle branch block above 150, we always go to coronary sinus first. But if after our attempts, the QRS complex does not look nice, and nice usually today means below 120 milliseconds, then we usually add a his bundle or a left bundle lead on top. And I think the additional lead in this context is absolute worth the effort.
Thank you very much, Carsten. Any comment, Aaron?
Yeah, if I may add, I would say I do it routinely in CRTP indications. Instead of placing a right ventricular lead at the right ventricular septum or apex, I go for left bundle branch error pacing plus in the coronary sinus. And if the patient's in sinus rhythm, he or she gets an atrial lead. In this patient, it was atrial fibrillation. So because there's only a maximum of 3 ports you can connect leads to. The issue is in patients with an ICD indication, because then it's difficult to put the ICD lead, a conduction system pacing lead, an atrial lead, and a coronary sinus lead. There are ways of doing it with the connectors and so forth, but it's, I would say, a little bit clumsy. What we're seeing now are new ICD leads, which allow you to deliver conduction system pacing through left bundle branch error pacing with the ICD lead. And that, I would say, would facilitate the delivery of LOT CRT. There are several companies that have these ICD leads coming out, and they'll be available for, I would say, routine practice in the near future. So we're probably moving towards in BIV pacing indications in CRTD indicated patients to LOT CRT, which will probably, further improve or increase the benefit of CRT. It just gives you more options.
Thank you. I think it was important to mention this technical point. I have a question, because you mentioned in your question, Haran, VT ablation. And in fact, you didn't consider this, Rosé as well. So what is your position in a patient with, I would remind that it's not a clinical VT, it was an inducible VT. So would you consider as first-line therapy VT ablation for this patient with non-ischemic cardiomyopathy?
That's a very good question. For me, it's not that clear for different reasons. One is the one stated by Haran. You need to cope with each problem at each time. So cope with everything at the same time, it won't benefit the patient. And in this particular case, VT is not that clear the cause of syncope, number one. Number two, the inducible one maybe is not the clinical one. Secondly, it has already substrate that may impose the patient to further arrhythmia problems in the future. And as you remember in the guidelines, it said 2 factors for ICD implantation. And then there were syncope and VT inducible, but also leg gadolinium enhancement in MRI. So the patient has already an indication for an ICD and unclear clinical VT. So I will start implanting a device, and if the patient develops VT at follow-up, maybe it's the time to reconsider VT ablation.
Okay, so for you, no VT ablation as first-line therapy. Do you agree, Karsten, for this type of patient?
Yeah, absolutely. Of course, when you see this beautiful induced VT that Haran showed, only 2 extra beats, and then you have a monomorphic, not too fast VT, this is very tempting to ablate it. But if you look at the MRI, you can definitely see, just like Jose said, this guy, even if you ablate the VT successfully, is at high risk that he will receive VTs from other places as well. So I would also have exactly the same opinion, implant the ICD, and if VT remains a problem, you can still ablate at a different time. Don't do everything at the same time, because then in the end you might end up with complications.
Thank you very much. So I think that time is running, and I want to thank all of you for this very interesting case presented by Haran, controversial discussion a little bit with Jose, but this is our life, and it's the reason why we have to combine all forces together and to discuss and not to make any decision alone in his office. And I thank also our fellow physician for being there, and Karsten, which is one of the most famous European device physician, for being there. I hope you really enjoy this session as we did. And I think that life is not so easy, but I think that if we join forces for our patient, we will do a better job. So please stay tuned, and because now we have a presentation by Emiliano Fiori about a case called a simplified 3-step hemodynamic assessment, the volume upper arm exercise protocol. I'm sure I will learn a lot with this presentation. Thank you very much to all of you, and thank you to you for attending this session.
Thank you.
Thank you.
Exercise-invasive hemodynamics is an established tool in the diagnosis of heart failure with preserved ejection fraction. However, its routine implementation is often hampered by procedural complexity and extended cath lab time. The objective of our study is to evaluate a pragmatic 3-step protocol combining volume challenge and upper arm exercise to identify the hemodynamic FPEF phenotype. Our study cohort consists of consecutive patients with undetermined dyspnea with New York Heart Association class 2 and 3, preserved ejection fraction, and an intermediate clinical likelihood of FPEF, compared to controls, patients without dyspnea referred to our cath lab for other indications. This is the protocol. It consists of 3 hemodynamic assessments, the first at baseline, supine, the second after a volume load of 7 ml administered in more or less 3 minutes, and the third hemodynamic assessment during upper arm exercise. To categorize and diagnose FPEF, we adopted established pulmonary capillary wedge pressure thresholds for each hemodynamic assessment step. The ultimate aim of this study is to provide clinicians an easily deployable and accessible diagnostic tool, potentially available in all cath labs, to unmask FPEF in its earlier stage. Looking at the baseline characteristics, not surprisingly, symptomatic patients were older, presented higher NT-proBNP levels, and a poorer kidney function. However, quite interestingly, when focusing on echocardiographic structural and functional parameters, we observed that the populations are the two groups are very similar. And looking at the hemodynamic variables, only mean pulmonary artery pressure presented a statistically significant higher value in symptomatic patients compared to asymptomatic patients. Looking at the continuous variation of the hemodynamic parameters within the exercise protocol, we can observe that patients with dyspnea exhibited a significantly greater increase in filling pressures, namely right atrial pressure, mean pulmonary artery pressure, and pulmonary capillary wedge pressure at both after volume challenge and after exercise. This came along with an increase in stress blood volume and a blunted increase in cardiac output, which are two hallmarks of the HFpEF hemodynamic phenotype. Looking at the identification of diagnostic thresholds for HFpEF throughout the protocol, so looking at the categorical results, only 6 patients qualified as HFpEF at baseline, 28 after volume challenge, and even more importantly, 11 more during upper arm exercise. So overall, 39 out of 52 patients, around 75% of our cohort, qualified as HFpEF. Zooming in this subgroup of patients with high maximal pulmonary capillary wedge pressure, it is interesting to notice that, of course, this presented with higher filling pressures, but more importantly, these pressures were still within the normal range, stressing once more the relevance of exercise dynamic testing in the diagnosis of HFpEF syndrome. So to conclude, this 3-step protocol with volume expansion and upper arm exercise elicited differential responses, identifying a well-defined subgroup of patients meeting the hemodynamic HFpEF criteria. This pragmatic protocol is swift and easily implementable in the routine cath lab setting, representing a possible alternative to supine exercise testing in unmasking HFpEF phenotype. Thank you for your attention.
Hello. Welcome from beautiful and sunny Paris, from where we broadcast this session about bringing intelligence to decongestion management. This session is sponsored by Reprieve Cardiovascular, and it's my great pleasure. My name is Jan Biegus. I'm from Wrocław Medical University, Poland, to co-host this session with Julio Núñez from Valencia, Spain. And we will talk about the decongestion, the advancements of decongestion, intelligent decongestion, and the way we can actually handle the congestion in patients admitted to the to the hospital because of decompensated heart failure. We need to keep in mind that majority of patients with heart failure hospitalization actually present the congestion itself. The major objective of our session is to learn how intelligent and personalized congestion and the decongestion strategies can actually overcome the standard protocols. We will also hope that we will be able to help you understand the clinical importance of sodium-guided decongestion and to, let's say, inspire the next generation of continuum care of acutely decompensated heart failure. Without further ado, it's my great pleasure to introduce Julio Núñez, who will present the clinical case for us. Julio, the floor is yours.
Thanks, Jan, for this kind presentation. I'm happy to be here with these superheroes of decongestion. Thanks. This is a very provocative title, Jan, putting in a relevant problem, optimizing the decongestion therapy. This is a really relevant problem. We don't really know how to treat many patients. This is very important issue in clinical practice. We really know that volume overload explains most of symptoms and signs in patients with worsening heart failure. However, traditional decongestion approach are mostly cases empirical and based guided, but many cases subjective parameters. So we need precision medicine in decongestion. So in the next minutes, I'm going to present a case that illustrates this problem. This is Peter. Peter is a 73-year-old male. Patient had prior chronic heart failure, ischemic heart disease, left ventricular ejection fraction last echo 36%. The patient is visited in a heart failure unit in stable New York Heart Class 2. Patient also has as a comorbidity permanent AFib and CKD3A. And patient is on treatment, stable treatment with furosemide 80 milligrams daily, sacubitril valsartan low doses, bisoprolol 5 milligrams daily, eplerenone 25 daily, and dapagliflozin. Patient, we may say that patient is optimized in terms of GDMT. The patient came to emergency department with progressive dyspnea, decreased urinary output, peripheral edema, evidence symptoms, signs of volume overload. No identifiable precipitating factor. The patient on admission had blood pressure 90/60, heart rate 92, AFib, GFR 41, and NT-proBNP, high NT-proBNP, higher than close to 1,000 picograms milliliter, and evident signs of volume overload also expressed by higher values of CA125, a marker of extravascular volume overload. Here in emergency room, patient received an echo exam that reveals severe left ventricular systolic dysfunction and severe MR and severe tricuspid regurgitation. The patient received intravenous furosemide dose at 160 milligrams daily, was initially prescribed. At this moment, the physician decided to stop sacubitril valsartan and eplerenone, and the patient was admitted to cardiology ward. The evolution of patient the next days, patient in the first day, the urinary output was slightly above 2 liters. Dyspnea slightly improvement, The day 2, 3 was the same, slight improvement in terms of symptoms, signs, with daily urinary output about slightly above 2 liters. The day 4, patient refers to be better. Patient wants to go home. Everyone wants to be home, and the physician decided to discharge the patient to home day 5. No clear algorithm, no clear protocol, just patient feel a little bit better. The patient was discharged on the same guideline medical therapy, 4 pillars, including sacubitril, valsartan, beta blockers, pleromone, and SGLT2 inhibitor, together with furosemide dose daily of 120 milligrams daily. The patient was scheduled for an early post-discharge visit in the heart failure unit. What happens with the patient with this conventional approach? Patient came once again 7 days after discharge with recongestion. Look at the patient, evident symptoms, signs of volume overload. And this is not an anecdotal story. This is highly frequent story. This is a sad story that happens in up to 30% at 90 days after discharge. So we really have a problem. So at this moment, I would like to introduce Marta Cobo that will try to help us how to improve this traditional, conventional diuretic approach. We are failing with this one.
Thank you, Julio. Well, in the next session, we will review the state of the science and conventional decongestion, current practices, what the guidelines recommends, and what we have learned from recent clinical trials. And we all agree with Julio that too many patients are discharged with residual congestion. And to help improve the numbers Julio just showed us, the Heart Failure Association published this consensus document in 2019 that was later incorporated in the European Heart Failure Guidelines. And this was the first structured framework that provided a step-by-step protocol that helped us in assessing the diuretic response in acute heart failure. And let me walk through it. The first thing is straightforward. When the patient is admitted in the emergency room with volume overload, please administer intravenous loop diuretic as soon as possible. If the patient is already on diuretic therapy, administer 1 to 2 times the dose the patient was taking at home. This high dose comes from the iHF trial that was the first study that evaluated diuretic strategies in acute heart failure. And the key finding was that the high dose therapy, defined as 2.5, the oral dose, resulted in greater symptom relief and a better decongestion 72 hours later. And after this initial treatment, the document proposes one of the key things of the document: please be proactive, perform an early evaluation of diuretic response by measuring urinary sodium at 2 hours and urinary volume after 6 hours. Because as Dr. De La Spriella will explain shortly, a low urinary sodium, particularly below 50 millicubic liters, is associated with a worse diuretic response and increased risk of rehospitalization and mortality during follow-up. Therefore, if the urinary sodium is low or the diuresis is low, the protocol recommends escalate the loop diuretic dose until a maximum dose of 400 to 600 milligrams of furosemide. And from the second day onwards, the protocol recommends first reassess the congestion. And there it is, another important message from this document. Given the limitations of physical examination on detecting residual congestion, this guidance recommends a multiparametric assessment of fluid overload, incorporating biomarkers and imaging techniques such as vena cava imaging and lung ultrasound. And please let me add 3 additional tools that may help us, like CA125, that is a very useful biomarker in detecting tissue congestion, the Vexus score that helps us to identify intravascular congestion by measuring the venous flow of porta, suprahepatic, and renal veins, and the increase of weight with its well-known limitations. So if we detect residual congestion and the urinary output is below 3 liters, an escalation of therapy is recommended. This 3 liters threshold was evaluated in the CARIS-HF trial. That was an interesting study that evaluated a protocol diuretic treatment versus ultrafiltration in patients with acute heart failure and cardiorenal syndrome. It was based on the previous oral dose, and it consisted of intravenous bolus, the addition of a continuous infusion, and the addition of metolazone if needed. And this protocol led to a better renal preservation compared to ultrafiltration. And finally, the protocol recommends combination diuretic therapy, but only when a high loop diuretic therapy has been reached. But however, this recommendation seems outdated given the recent trials that have evaluated a second diuretic, like the chlorotic with the hydrochlorothiazide, the Advor with the acetazolamide, or the Impulse with the empagliflozin. All of them show that an earlier combination leads to an earlier and more effective decongestion. And this brings us with Julio's patient, with Peter, and he was admitted during a trip to Madrid. And despite we applied the European document, we administered twice the dose, we performed an early evaluation, we escalated on day 1 to the maximum loop diuretic, added dapagliflozin, and on the 3rd day, we also added chlortalidone. The initial evolution was good, as you can see in the slide, by losing weight, the clinical examination, but we needed to escalate further, adding acetosalamide, spironolactone, and even applying venous leg compression after achieving euvolemia 32 days after admission. Therefore, although I feel that we are moving in the right direction, I really think that we need to better assess diuretic response in order to translate it into an earlier and more effective therapeutical decisions. Thank you.
Thank you very much, Marta. And now I would like to introduce Dr. Rafael Espilla, who will talk about the science behind the decongestion management and why we fail in, I would say, some standard protocols. Rafa.
Thank you very much, Jan. In the next few minutes, I'm going to discuss with you the reasons why I think we need to change our current practice using traditional metrics like daily weight loss or net fluid balance to a more science-based approach, which is urinary sodium. This is my disclosures. Which are the problems with the commonly used metrics for assessing diuretic response? We all use changes in weight loss or net fluid output to assess the decongestion of patients admitted because of an admission with acute heart failure. And these metrics are applied in current clinical practice and also in trials. But the reality, if we look at the data, this is data from the DOSE trial, ESCAPE trial, and the PEN cohort. If you see the Bland-Altman plots here, there is a substantial disagreement between changes in weight and net fluid output, which puts us in evidence that if these metrics are essentially measuring the same signal, how is possible to have this substantial lack of correlation between those? There are a number of reasons. This indicates that one or both of the metrics are incorrect in a substantial percentage of cases. If we see the fluid balance side, there are a number of reasons like uncorrected intake, staff and patients non-adherence, food and fluid intake, which is not measured. And if we see the daily weight challenges are basically on different scales used, the patient, which is fragile and his inability to stand to the scale, the bed scale problems. I mean, this is a challenge that we also see in daily practice, that lack of the accurateness of these metrics. Even if we have dedicated staff nurses with motivated and are able to do these metrics in an accurate way, there is a substantial delay between we have this data and we modify current treatment. Diuretics are almost titrate or set the dose one per day, and we have the information the day after. So we always are the information, the gesture information, we almost 24 hours behind, and we make decisions based on these metrics that are inaccurate, that are delayed, and that are not associated with better outcomes, as you can see here. Both metrics are highly variable, and in current trials have not shown any consistent benefit in terms of outcomes. So we need a paradigm shift. We need to bear in mind that the pathophysiology of extracellular volume expansion is not based on water retention. It's basically on sodium retention, and net fluid and weight loss are most entirely the result of changes in water. If you see these two patients here, patient number 1 and patient number 2, they both had the same urinary volume, 2.3 liters in 24 hours. You may say this is a good response, but if we look at the urine content, you can see that patient number 1 has a substantial lower urinary sodium in 24 hours. It's basically a merely dilated urine, whereas the patient number 2 is actually desalinating, is excreting an amount of sodium that is what we want. And this has several prognostic implications. This is data from the iHF trial, and you can see here that patients with a negative sodium balance, a negative fluid balance, but still positive sodium balance are those who have the worst prognosis. So this is a therapeutic target. And how we can use a parameter that can ideally give us information both of sodium removal but also on sodium removal. This is the natriuretic response predicted equation from the group of Jeffrey Tistani. And as you can see here in the graph below, there is an almost linear association between the predicted urinary sodium equation and the actual measured sodium output. And with a very good, in every threshold that they measured, there is a good correlation with the observed urinary sodium output and urinary output. But we need to bear in mind that it's not just important to have the urinary sodium at just one point during the decongestion assessment. This is data from Jan showing us that the trajectory of urinary sodium during admission is also important, and patients who we achieved a negative sodium balance with a substantial higher urinary sodium during admission had better prognosis than those who achieved a lower and progressively lower urinary sodium during the first 48 hours of decongestion management. But we also need to have in mind that even if you have the same urinary volume during the days of admission, the urinary content is going to be progressively dropping in the next few days because of two main points. Because you are achieving a negative sodium balance, which is your objective, or because the patient is not responding in an appropriate way. And the best way to integrate this information is by combining these parameters with, of course, clinical examination and other multiparametric parameters to see which of these conditions is what you're facing on. I think the most potent and strongest evidence so far about the role of urinary sodium and outcomes is data from the ADVOR trial, in which you can see here that patient achieving a greater natriuretic response was associated with faster decongestion, and this translates into a shorter length of stay. And if you see at the right, assessing urinary sodium as a continuous variable, you can see clearly that above 80 of weighted urinary sodium, there is a progressive protective effect during the next 90 days after the discharge. So this is a therapeutic target in our patients. However, in practice, there are a number of barriers that preclude us to use this useful metric in our daily practice. This is data from a Spanish national survey, including more than 165 hospitals and more than 400 physicians with diverse specialities. And you can see here that implementation of urinary sodium in practice is around 20 to the best of 30%. There are a number of reasons of that: lack of protocols, therapeutic inertia, time on human resources, but this is the reality. So we need more actionable and automatic strategies. This is an example of the gel diuretic pathway that uses an automatic approach based on the natriuretic predicted response equation, in which every 6 hours the nurse have the result of the system and tell her exactly which is the next dose that she needs to prescribe to patients, and this translates into an improve in total urine output, net fluid output, and weight loss using this algorithm. So in conclusion, we need to move away from the traditional metrics, and the science tells us that sodium is the target, and probably an automatic approach is the better way to achieve this. So in the next minutes, Jan is going to tell us about the intelligent decongestion management with the reproved cardiovascular system. Jan?
Thank you, Rafa. Thank you very much, and I will try to get you facilitated with intelligent decongestion in a few minutes. These are my disclosures. I would like to start with the notion that we've been using loop diuretics for 6 decades, but how we use it is more like a try and error decongestion, as was already mentioned, rather than, I would say, personalized approach. Although we've been using the drug for more than 60 years, there are several unanswered questions, like what is the best starting dose of the loop diuretics in a single patient that we actually need to treat, what response should we measure, when should we reassess the patient, and what is the optimal timing of the next dose of the loop diuretics. So taking all this together, we are, I would say, far away from something that we could call a personalized decongestion. Although, of course, as you see here on the left side of the graph, the graph showing our attempt based on urinary sodium. So the subject of this lecture is intelligent decongestion. So I just wanted to point out several features that this intelligent decongestion should have. And what I think it should have, it should be personalized, which means it should be adjusted to the single patient. It should allow us for dynamic, real-time adjustment for the therapy, changing during the therapy. It should, of course, preserve the renal function, prevent both over the congestion as well as leaving a patient with residual congestion. And it should, of course, integrate several signals like urine output, fluid balance, clinical status, and other physiological responses into the one decision-making algorithm. And, of course, making it easy and detectable early identification of inadequate patients with inadequate diuretic response. So reprieve therapy is something that gets us closer to this goal because the device itself is actually connected to the patient with a line that can actually administer loop diuretics in a real time. It also is connected through the urinary catheter and can measure the response, the urinary volume. And the third thing that it actually does, it also infuses the saline during the decongestion, which is quite, I would say, not so straightforward for most of us, but it actually is meant to prevent both sodium and intravascular volume depletion. And as you see here, there is a graph showing the decongestion of one patient during the reprieve therapy. And during this therapy, actually, the red line is something that shows you the dose of the loop diuretics. So there are like 3 or 4 boluses of loop diuretics, which were followed by a continuous infusion, which allowed actually a smooth decongestion. So what does this device do? First of all, it is much closer to the personalized medicine because it actually has something that is called rapid dose finding algorithm that allows the device to find the dose that is effective in a single patient, in a single individual. Then it allows to maintain the dose and re-ramp if necessary during the therapy. And the third thing that will probably be discussed later on, it actually allows the infusion of the saline. So FAST trial is a trial that was meant to test the reprieve therapy against standard of care, and patients with vast fluid overload were randomized in a one-to-one fashion in a randomized controlled pilot study showing that the patients eligible for the trial were patients with vast fluid overload, almost more than 4.5 kilograms of estimated fluid overload, and patients with eGFR less than 20 were actually excluded. So the primary endpoint of the trial was efficacy endpoint was 24-hour urine sodium output, and as you see here, there are around 100 patients were randomized, 52 into reprieve arm and 44 into the optimal medical treatment arm. The patients were in their 60s with eGFR around 55, 57, and ejection fraction just less than 40. So here you can see the distribution of the loop diuretic dose the patient received, and you can clearly see that on the blue that patients on a device received much higher dose of loop diuretics, but it translated into shorter duration of the therapy, and it was also associated with an infusion of the saline approximately 3.3 liters per patient. In terms of efficacy and safety results, the reprieve therapy had significantly higher natriuresis normalized for 24 hours. It was safe, as you see, there was no safety signals. And as you see here, it not only natriuresis itself, but net sodium excretion as well as total urine output as well as weight loss was significantly better in patients allocated to the reprieve therapy. There is, of course, a hypothesis-generating graph showing the risk of recurrence of heart failure, hospitalization, and death during 90 days after the treatment. To put the whole results into the perspective of other trials in acute heart failure, you can clearly see that during the reprieve therapy, the weight loss was significantly higher than in other trials, and it was actually related with lower risk of worsening of renal function over the controls compared to the other therapies. So to conclude, in fluid overloaded patients, reprieve therapy was associated with faster and more favorable effects on sodium output, urine output, weight loss, with no signals regarding the kidney harm or any other safety signals. With that, I will conclude, and I will give back the floor to Rafa, who will show us the case again.
Yeah, and here we have a typical case of a patient who is admitted because of decompensated heart failure. It was a 50-year-old male with a left ventricular ejection fraction of 40%, a moderate mitral regurgitation, and was previously admitted before. And when we see the physical exam, he has substantial signs of fluid expansion, leg edema 4+, crackles, orthopnea, increased jugular venous pressure, also pleural effusion, and an estimated excess volume of around 8 liters. The vital signs and weight, the blood pressure was 128/75. The weight was 101 kilograms. with very high NT-proBNP, with serum creatinine of 1.3 and GFR about 60, serum sodium 137, and potassium 4.5. And in red here, we show parameters indicative of probable diuretic resistance as serum chloride of 98 and urinary sodium after the initial bolus of furosemide of 80 milligrams of 83, less than 100. So the treatment prior to admission was furosemide 40 milligrams, dapagliflozin 10 milligrams, spironolactone 25, and was receiving valsartan 160 milligrams. So the patient was admitted, fulfilled the criteria, the eligibility criteria to be enrolled in the FAST trial, and was allocated to the reprieve system arm. And as you can see here, this is the response. In the first part, the upper part, you see that the diuretic infusion rate, as Jan explained before, the system, the first phase is the dose-finding phase, in which the system is going to deliver a continuous infusion of furosemide to achieve a target of 525 milliliters per hour of diuresis during the first 2 hours. And during this initial dose-finding phase, the system will automatically infuse saline in a 1-to-1 ratio to achieve or 250 milliliters of saline or 1 hour, whichever comes first. After that, a continuous infusion phase begins with 20% of the dose-finding dose that was achieved during the dose-finding phase. And as you can see here in the lower graph, the urinary rate was initially very fast, increasing the rate of urine. Also, the saline rate was fast, but after the first infusion, the urine rate becomes back down again. And the system asked the physician to administer a new ramp to achieve a higher infusion phase. And this was what occurred. As you can see, there was an increase in the urine rate again that was maintained during therapy. And in the yellow line, you can see the saline rate that was around 300 milliliters per hour. So the net fluid balance in green, the green line, was drawing back to the negative of 8 liters. And the resume of the therapy, you can see here that the duration of the therapy was around 20 hours with a total urine or around almost 12 liters with an average of 161 milliliters per hour. The fluid volume replaced as a part of the reprieve therapy was around 4 liters. The total volume removed was negative 7.4 liters with an average per hour of 360. The total furosemide administered was around 900 milligrams with an average of 43 milligrams per hour. It's a very high dose. The estimated fluid that was 8 liters, we achieved our goal, and the patient was successfully decongested and was discharged less than 48 hours from admission. And now, how we can overcome after we achieve the decongestion itself, how can get the patient out of the hospital, and that's what Alex is going to tell us.
Yeah, thank you very, very much. Now, there is a secret in this case report, is that the patient came to Paris. And then together with you guys, we are going to see how we are going to manage this patient. And bravo to show this case, because it's really a case that we are all facing. A patient who initially came, looks beautiful when he was discharged first, and then he came back again with a new discharge, with a new congestion, and then you discharge him very well after an active decongestion. Now the question is, how are we going to manage this patient? Now, as I said, you did very well the first hours, combining oxygen if needed, and this is what we published few years ago saying that for decades, and Jan was mentioning earlier, the action was during the first minutes. How can we decongest the patient? And we know that, in fact, the journey of acute heart failure is a little bit more complex. The patient is staying at the hospital. Julio said earlier, we have a problem with those patients that would like to leave the hospital as early as possible, and we need to use that period before discharge to really manage this patient as much as we can. Then again, I took your patients who took an airplane to come to Paris, and here's the hemodynamics that you showed. Here's the biology, very high NT-proBNP, almost 6,500. Creatinine slightly increased, eGFR 58. Potassium 4.5, I think it's important to mention this. And the oral therapy was valsartan, 40 milligram times 2, spironolactone 25, and dapagliflozin 10 milligram. Now, what are we going to face, and we already faced this in this patient, is that at discharge, and Marta, you said it earlier, we all think that the patient is discharged and he's euvolemic, and we know that we are wrong. Even if we are writing in the report that the patient is euvolemic and normovolemic, we know that it's not true. Many of them are discharged with still a congestion. And I like to show this data, because this data we asked to the physician in charge, so the cardiologist in charge, how was the patient at admission? You see that at admission 70% were wet and warm, but we told the same cardiologist, but when the patient is discharged, how was it? And you see that when really they're examining the patient, almost 1/3 is still discharged when they're leaving the hospital. And I used to remember people that in this study, many of the patients had a body weight that was even higher at discharge than really at admission. And we should keep this in mind, and this echo, I think, what you showed earlier. Then we did a strong procedure, and the strong procedure came a little bit really from the concept of cancer, saying when the patient has a cancer, and we know that heart failure is really, unfortunately, killing patients more than any cancer. We had this idea to say when the patient comes with an acute heart failure, even more importantly in your scenario, because the patient came again and again, we should really start the oral medication that is going to cut this neuroendocrine system. And what we did was strong. We indeed gave oral diuretics, but we also gave to the patient literally half of the dose of ACE or ARNI, half of the dose, optimal dose of beta blocker, and half of MRA together in the morning, together in the mouth of the patient to start really oral medication. Then the patient was discharged, and in the protocol, we said this patient cannot be left alone and going back and not being followed. We said, okay, those patients are clearly in emergency. We need to see them back very, very quickly. And we decided to see them in the weeks following discharge. Now, this result is interesting. In red is the patients we followed. In blue is the patients that unfortunately were followed in town. And you see that the management is unfortunately poor. But let's focus on those who the investigator managed in the high-intensity care arm. And you can see, for example, let's look on beta blocker at 90 days. You see that beta blocker at 90 days, half of the patient could have a full dose. And it's important to see that even at 90 days, we hardly could give a full dose to more than 50% of the patient. But this is already great, because we go from few percent to half of the patient. And the other patients, they are not left without anything. You see that the other patient had between, as you can see, between half and full dose. And really we can say that 80% of the patients who came with an acute heart failure had the minimum half and even a full dose. Was it translated in outcome? Yes. And maybe during the discussion we will come back to this. Although it looks counterintuitive to have patients with congestion, that we start the medications before discharge and we give early after discharge, yes, if you push the fire, if you push the treatment, you can achieve an improvement in many parameters, and indeed readmission and death. But this is really, for me, one of the most important slides, because this was not expected. It's not something that we looked for, and we were surprised to see in the high-intensity care arm, although there was a slightly lower dose of diuretics, we saw all the parameters of decongestion being improved
at 90 days. And I love to show this analysis of Jan Biegus-Hinchak, showing that the y-axis you have decongestion, then 0.75, 0.50, etc. means that the patient is more and more decongested. And you see that the more the dose of GDMT are close to the optimal dose at 90 days, the more the patient is decongested. Now, Strong was repeated in several settings. This is in Harvard, Jim Januzzi and Spahilari. They did echo before and after the implementation of Strong. They could show first that the patient is better, is improving, NYHA class has really improved. But also we see in only few months, we see a remodeling. Ejection fraction is better, 6%, but maybe even more importantly, the volume of the left atria and the left ventricle are down. And indeed, by definition, we saw an improvement of mitral regurgitation. And this is now seen by many groups. And really, I love to show this data to show that this effect, this powerful effect of starting the medication before discharge, we see it already 1 week after discharge. We measured in this study done in Tunisia, we measured respiration rate on the top left, and on the top right, we measured SpO2. And you see that within 1 week, this is really unbelievable. Within 1 week, we saw respiration rate coming back to normal, and we saw SpO2 coming back to normal. Then it's not only congestion that probably went very quickly, but there's also many other neuroendocrine systems in place that were improved. And you see that in this trial, indeed, we confirmed that at 90 days and 180 days, there was an improvement in readmission and death. This led to this recommendation that you know before discharge and after the follow-up visit. And these guidelines, they said, please extend it at least for the first 3 months to any ejection fraction. And they also said, please add a gliflozin. This is important. And I would like also to show you this network results that was done in China. As you can see here, more than 600 accredited centers, more than 400,000 acute heart failure patients. And in fact, we accredited those centers. And you see here that within 12 months of putting a GDMT implementation, within 12 months, let's say if we, in the country, the Minister of Health said today we start, March the next year, we already would see a decrease in the readmission and survival. And you see that, interestingly, implementation is improving every year, means that with the same centers, with the same network, because the nurses, medical students, etc., everybody is learning, then you see that every additional year it's good. Then coming back to this lovely patient who would like to see the Eiffel Tower, then before discharge, at least this would be my way of doing, and maybe we can discuss this later, 40 milligram would have been slow for me, a low dose. Then I would go for a higher dose because the NT-proBNP, remember, was very high, 6.5. And because I'm thinking beta blocker would be probably better tolerated if we can decongest the patient, then I would go for higher. I will keep the medication that you put, and I would start with bisoprolol 2.5. At week 2, indeed, I'm going to check what I did before discharge. Then I would see whether furosemide was the right dose or whether I need to increase. And this is based on NT-proBNP. Indeed, if I start to see NT-proBNP going down, I will rethink increasing the dose. But if NT-proBNP would stay the same, definitely I will increase even more furosemide. Valsartan blood pressure was good. Then valsartan I would go to 160 times 2. Spironolactone I would go to 50 if potassium is really unchanged. Dapagliflozin would stay the same. And based on heart rate and based on the NT-proBNP that we heard earlier, either I pause bisoprolol or I would keep going again, because my idea is here is the more there is optimal dose, the more I will decongest the patient. Thank you very much.
Thank you so much.
Hello. Well, now it's a pleasure to me to moderate this session with such great speakers. If the audience have any questions, they can send it to the tablet. And now, well, we can start with any question for our speakers. Marta, Rafa speak about the obtained urinary sodium at 2 hours. Well, how is urine sodium currently measured and used in your clinical practice? If you can detect some barriers, and how do you change it?
Okay, well, as I showed in the protocol, the guidelines recommend us to assess urinary sodium in a urinary spot at 2 hours after the first loop diuretic administration. But I think we have a time window of 6 hours in which low natriuresis can help us to improve, to increase diuretic treatment. Afterwards, as Rafael explained perfectly, as sodium excess is removed, the urine becomes hypotonic, and we don't really know if a low natriuresis is related to inadequate decongestion or if the patient is diuretic unresponsive. So I think in that moment it's very important to assess the multiparametric approach of congestion, and if the urinary sodium is low, perhaps we need to push harder, but no evidence. We don't have no evidence. And regarding the other question, we, as Rafa showed us, we performed a national survey, and it was really striking. Only 18% used this natriuretic guided strategy. And the main barriers were the lack of training. And I think this is one thing that we should improve, because the emergency department physicians, at least in Spain, are the first physicians who attend the patient. So I think we need to improve these pathways and the training. And the other limitation was that half of the respondents perceived a low clinical priority. And I think it's true that natriuresis-guided therapy has not shown reduced hospitalization or reduced mortality, but I think, like heart failure specialists, we need to highlight the importance of an earlier decongestion. And I think we should improve in research, but I think we should highlight that.
Jan, can I just add to this? Two comments. First one is that if the awareness, I'm afraid that in Poland it will be like 10% centers actually measuring sodium, but it is probably because lack of awareness. This is what you just said. So this is great that we can talk about it and just say that this is very important. And the second thing is that we did a research, and we know now that we don't really need to wait this 2 hours, right? If the patient empties their urinary bladder and then we give them the diuretic, so we can measure actually the first urine that comes after this IV diuretic, and usually it's around 1 hour, and this is almost the same as the sample that is taken at 2 hours. So this might actually make life easier for the clinicians, right? That you don't really need to set the clock and say, okay, in 2 hours I'll be back, but you can just take the sample that is first post the loop diuretic dose.
Well, one question from the audience. In acute decompensated heart failure, patients with significant congestion after starting diuretics, if patients develop rise in bone and creatinine, should I reduce the diuretics if it's still congested clinically?
Rafa? I can answer that, yes. It is expected to have an initial rise in creatinine during decongestion, and this should not give us a signal to stop diuretics, especially if we are absolutely certain that the patient is still congested, because this is not a signal of kidney injury itself. It's more an hemodynamic process that is happening within the glomerulus, and we need to continue diuretics because of this is the only way to improve outcomes.
Okay. Jan?
Can I just add a little bit to this? It might sound a little bit controversial, but actually what we learn from Reprieve and what we really do in our everyday clinical practice, if we have a situation like this, we have a patient with fluid overload who urinates like 3 liters per day, and his creatinine goes up. From my perspective, is information that we need to give the fluid, sodium and chloride to this patient. And actually reprieve therapy shows it that the risk of this scenario is much lower in patients who receive this signal. We don't really know what the signal is, but the signal probably we prevent intravascular depletion and sodium, relative sodium depletion, but this is what we do. And we do not stop the treatment, we do not decrease the treatment, but we try to adapt to the situation.
Well, Julio?
Just a summary for all of you that are listening and viewing us. It's really important to leave behind just interpretation of GFR or serum creatinine in this type of patients and integrate, in a multi-parametric perspective, putting in first place, clinical evolution of patients, diuresis, natriuresis. This is relevant. And leave behind a comprehensive interpretation of renal changes into this multi-comprehensive assessment.
Okay, perfect. Julio, other question. Short question, short answer, please. What are the main indications for reprieve system and what are the best candidates for it?
We really don't know, but if we check the results of faster trial and the eligibility criteria for this trial that is ongoing, we need to focus on patients with fluid overload, and risk of insufficient diuretic response. Okay. I think in this scenario, the machine of this reprieve system will achieve positive results.
Perfect. Jan, for you, what is the importance of the isotonic saline in this trial, and why is so important for these results?
Thank you for the question, but I will not be short. There's no way to be short to answering this question, but to be honest, well, I think the graph, I showed you the graph with the dose of loop diuretics that both arms received, and the reprieve arm actually received much higher doses of the loop diuretics, and it was super safe, right? So I think that giving back the saline during the decongestion, how I understand it, from physiological point of view, I think that we actually prevent something that is intravascular depletion. When the kidneys start to excrete a lot of volume, then there is a risk of shrinkage of the intravascular space because the refilling rate may not, accommodate for the urine output. So this is the first one. And the second one, I feel, this is my personal, I would say, belief, that we can, let's say, blunt the inner signal, physiological signal for the kidney to stop producing the urine because of the fact that it gets rid of a lot of sodium. If we give the sodium back, this actually makes it like the kidney is still producing a lot of volume.
Perfect. Other question is if you have to prevent or be aware with any situation along the trial, Rafael?
Yeah, absolutely. If you are giving a gram of furosemide and patients are producing 10 liters of urine per day, it is possible to get electrolyte abnormalities during this process, and you should monitor carefully the acid-base balance and electrolytes to prevent these complications that may happen during this substantial diuresis. So I think it is important to have these patients well controlled, and in fact, during the trial, you have to make at least 2 determinations of electrolytes in each patient to control of these problems.
I just want to point out that these potential side effects, this is not because of reprieve system. This is a potential safety issues about aggressive diuretic treatment. Exactly. Yeah.
Well, other question from the audience. During the diuretic therapy, if clinically congestion has improved but not NT-proBNP is still high, then we try increasing diuretics to reduce NT-proBNP also. Julio, Jan, Alexander.
I can take that one. I think NT-proBNP number rarely lies. I think if NT-proBNP, especially Marta mentioned this earlier, if you look on the evolution of NT-proBNP, maybe the first number could be related to many parameters, but if you have already one number, really the evolution, whether it goes up, stay stable, or go down, it's really very significant. Then I understand your point. The patient did a lot of diuresis, but NT-proBNP is still high, which we see often, we see very often. Really, there is something wrong, and the heart is still not coming back to normal. Then we should keep this in mind.
The only thing I would like to add is interpret the NT-proBNP in the context of the creatinine, because sometimes if the creatinine is high, then the NT-proBNP also increases and it's not reflected congestion. But I also agree with you that it's a signal of that something is happening.
Okay, perfect. 2 questions. Rafa.
We have time only for 1 question.
One question. Alexander.
Hola.
It is important to initiate GNT titration before discharge.
But then it's easy. Yes.
That's the so we have a time for second
question. Patient with severe congestion or Ansarca.
Very quickly. One, we really need to start before discharge, because for many reasons, including psychology, the patient, when he sees that you start several medications before discharge, he understands that something is wrong. And 2, I know it looks counterintuitive by saying, but the patient is still not decongested, how you start? Yes, we really need to start.
Can I ask you something about the case? I kind of missed the sacubitril valsartan there. Very high-risk patient. Why not changing valsartan for sacubitril valsartan in an earlier stage?
Yeah, in fact, I try to not be provocative, because in many countries you first need to increase valsartan, and usually the switch is later. But you're right, we can do it early.
Now I would like to ask Julio just to give us just a brief comment and end the discussion, please.
Yes, thanks, Jan. I would like to congratulate all of you, because excellent talks. I have learned a lot about this session, and also to be here in Paris is beautiful city and beautiful landscapes. So it's time to take home message. I think that really important topics we have discussed. First, we have appropriate decongestion remains a challenge, remains an unmet need. We are improving. I think we are on the right way. However, there are a lot of things to do. I think this is the first take-home message. Second, we need to move forward from this traditional, conventional diuretic approach, mainly based on empirical thoughts, subjective parameters, into a more precision medicine approach. I think it's absolutely necessary. In this regard, I think that urinary sodiums emerge as a crucial parameter, crucial biomarker for getting this objective. I think that all of you that treat this type of patient, worsening heart failure, fluid overload, aggressive diuretic response, need to integrate urinary sodium for monitoring and guidance therapy. I think it's absolutely necessary. But this is not a final history. We have an additional potential novel strategies for continuing improving. And in this regard, reprieve systems emerge as a promising approach for optimizing the congestion in patients with fluid overload and insufficient diuretic response. This is physiological sounds. We palliate, we control extravascular volume expansion, but keeping intravascular volume and avoiding all deleterious effects of intravascular depletion. I think we need results, but at least theoretically for me is absolutely marvelous. And finally, I say that we need to continue searching the right decongestion approach in our daily clinical practice. Thank you.
Thank you very much.
Thank you.
Fixing a mechanical heart. A 70-year-old man with an end-stage ischemic cardiomyopathy due to an anterior STEMI in 2022 and who received an LVAD implantation in November 2022 was admitted at our center due to worsening dyspnea and weight gain. In 2024, November, his clinical examination was remarkable for jugular vein distension, peripheral edema, and pleural effusion. His lab tests demonstrated clear signs of congestion, namely increased NT-proBNP levels, GGT, and bilirubin. His ECG was characterized by sinus rhythm with right bundle branch block, unremarkable for signs of acute ischemia, and more importantly, not different from previous ECG tracings. When looking at this chest X-ray on the right panel, we can see that compared to a previous chest X-ray obtained 1 year after LVAD implantation, so in 2023, his present chest radiogram demonstrates a sort of twisting of the impeller, pointing more towards the interventricular septum. The first instrumental assessment comprised a transthoracic echocardiogram, which demonstrates an enlarged right ventricular chamber associated with pulmonary hypertension, at least moderate tricuspid regurgitation, and increased central venous pressure as estimated by this dilated inferior vena cava. More interestingly, we could notice a periapical ventricular septal defect with left to right shunt. The patient underwent cardiac computer tomography angiography, which confirmed the presence of an apical VSD, which covered an area of 0.6 square millimeters with a diameter of 9 millimeters. Interestingly, we can see from this 3D reconstruction the tight relationship between the inflow cannula of the LVAD and the VSD. Our working hypothesis was that the clinical signs of right ventricular failure were mostly secondary to the VSD and shunting. To confirm our diagnosis and hypothesis, the patient underwent right heart catheterization and invasive RAM test. At baseline, the patient presented with a moderate left to right shunt with a QPQS of 1.3, and interestingly, this was associated with signs of right ventricular failure, namely a reduced pulmonary artery pulsatility index below 2, a right atrial pressure over capillary wedge pressure ratio of 1, and a right ventricular stroke work index below 4, namely 2.9. Increasing the speed during the ramp test, we observed a gradual reduction of pulmonary capillary wedge pressure due to the increased left ventricular unloading, and this was accompanied by improvement in right ventricular function indices alongside a neutralization of shunting. Overall, we were facing a unique hemodynamic scenario comprising VSD with left to right shunt of moderate entity, right ventricular failure in a patient with LVAD implanted as destination therapy. So after multidisciplinary heart team discussion, we opted for percutaneous closure to prevent further worsening of his heart failure condition and even paradoxical embolization. The procedure was performed in general anesthesia at the lowest LVAD speed tolerated in order to reduce the risk of device embolization and through an anterograde right to left approach, which allowed for a successful VSD closure. Here on the left panel we can see the transthoracic echo at follow-up, which confirms complete concealing of the VSD, and on the right a CCTA performed after VSD closure, which clearly describes the relationship between the inflow cannula and the Amplatzer device. The patients, from a clinical perspective, improved both as functional capacity, gaining a stable New York Heart Association Class 2, and demonstrated a marked reduction in NT-proBNP level. Thank you for your attention.
Welcome to the last scientific session of the iHF course. My name is José Luis Merino, and I am honor and pleasure to co-chair this session together with Sheila Cyril from Manitoba, Canada. We all know that PVCs are very frequent in heart failure, but it's not that clear when they have to be treated medically, ablated, or living a lot. So for this interesting topic, we have a fantastic panel of speakers. David Dunker from Hanover, Germany, Andrea Porta from Barcelona, Francesco Damiano Magri from Italy, and Francesco Spera from Italy as well. So the learning objective of this session are threefold: how to differentiate between benign PVCs from those leading to left ventricular dysfunction, to understand how to decide between PVC ablation, anti-arrhythmic therapy, or conservative monitoring, and finally, to recognize how timely intervention can reverse or at least improve PVC-induced heart failure. And without further delay, I hand over to my co-chair to introduce the first speaker.
Wonderful. So we're going to get started with a case now, and I have the pleasure of introducing Professor David Dunker from Hanover, Germany, and he's going to be discussing when many are too many, managing frequent PVCs in asymptomatic borderline LV function, something that we see in clinic quite a bit. So looking forward to your presentation.
Yeah, thank you very much, Shelley. When many are too many, I present a case to you from our clinic, and it was a 30-year-old male who was really asymptomatic, never went to the doctor for serious conditions, but now wanted to go diving and needed a diving license, and for this he needed a doctor's appointment and a check. And the general practitioner performed an ECG and found extrasystoles, like in this ECG. This is only showing 2, but in the Holter ECG, it resulted in 10% of PVCs in 24 hours. And then the doctor performed an additional echocardiography showing normal ejection fraction and no structural heart disease. And now the question is, what is the diagnosis, and do we need further diagnostic assessments? And if we look at the guidelines, with an ECG, a Holter, and an echocardiogram, we can already have a first assessment, and if there is no indicator of a structural heart disease, the diagnosis is already, this is idiopathic PVC. And that's good on the one side, because it makes the diagnosis easy, but it's also important to then not stop the further assessment, but then decide what is the next thing to do. Now, when the patient is asymptomatic, you see here, and the symptoms should be relevant and related to PVC, and in this patient, there was no indication for any of these. Then we look at the burden of PVCs, and if it's below 20% and above 10%, like in this patient, we have a class 1 recommendation for regular follow-ups of the ejection fraction to observe at least the patient. Now, this didn't happen really because the patient was feeling fine. He didn't like doctor's appointment, so he didn't went to any doctor for 2 years, but he wanted to continue diving. And in Germany, for younger patients, the diving license requires a renewal every 2 years. So after 2 years, he came back still for another check. And the re-evaluation now resolved in a Holter recording of 23% PVCs in 24 hours. And the echo now showed a borderline ejection fraction. You see his bigeminus here, and the ejection fraction was around 50%. So near normal, but in this case, if you have patients with PVCs resulting still in no symptoms, but now PVC burden above 20%, now the guidelines still say to have a regular follow-up of ejection fraction, but also to consider catheter ablation with a 2B indication. And now we had to discuss with this patient what to consider. And for this therapeutic decisions, there are several considerations to take into account, which is PVC morphology, PVC burden, LV function, and some other aspects to at least consider. Now, the most important is probably morphology. And we saw already the PVC. It's an inferior axis, so it's an outflow tract PVC and a left bundle branch block with a late transition, suggestive of an RVOT morphology, which is good because this is easy to reach with a catheter, easy to ablate, and low risk of adverse events. Now, the PVC burden is of importance too because a burden above 20% is associated with a deterioration of left ventricular ejection fraction in several studies, like you see here. And if the PVC burden is connected to a reduced ejection fraction, which was not the case in our patient, but if it was, you should consider if the patient is suspicious for coronary artery disease or valvular heart disease, and then execute further evaluations. And if not, you should still perform an MRI with a 2A indication and look for late gadolinium enhancement, because you need to decide, is this a structural heart disease aggravated by the PVCs or PVCs leading to PVC-induced cardiomyopathy? And if you have the impression that this is PVC-induced, you even would result in a class 1 indication for catheter ablation. Other aspects to consider are, for example, the QRS width, and the QRS duration was associated with cardiomyopathy, especially if above 150 milliseconds in some of these studies. So this is another point to consider. Retrograde P waves were also associated with LV ejection fraction reduction. You see on the left side an example of a PVC without retrograde P wave, and on the right side you see that you can identify a retrograde P wave at the very end of the QRS complex. And this shows us that there is an abnormal ventricular atrial contraction, maybe leading to LV dilation. Other aspects in the ECG could, for example, be the coupling interval that was also connected to adverse outcomes. And the coupling interval is the duration between the QRS complex, the last normal QRS complex, and the time until the PVC happens. And a longer coupling interval was associated with adverse outcomes. That may be counterintuitive, but it was very clear in the findings of one of these studies. Now, to consider treatments, we know that antiarrhythmic drugs can be considered in PVCs, and you can use this in symptomatic patients or in patients with LV dysfunction. But as you see here in this table from the guidelines, in asymptomatic patients, like our patient here, there is no indication for beta blocker, not even a recommendation for beta blockers, calcium antagonist, flecainide, and amiodarone, you see here, is a class 3 indication. Only the ablation is something to consider with a high burden, asymptomatic, and normal LV function. Now, what we did is that we discussed the patient with the patients the pros and cons and what we considered. We recommended a catheter ablation. It was an RVOT extrasystole. It was very easy to reach, very easy to ablate, and the procedure was very fast and uneventful. And you see that this was the Holter before the ablation. 2 years later, for another diving license check, the patient came back, and you see that now the Holter still showed a reduced PVC burden, lower than 1%, ejection fraction was normal, patient was still asymptomatic and still diving. So that was the case. Thanks for your attention.
Thank you, David. Very, very nice case, very a good example of what is often seen in clinical practice. You were referring that your patient was asymptomatic. I think that this is clear when you are thinking about palpitations. But then there are other subtle symptoms like poor functional class or deterioration of exercise capacity. So this happens, for example, in atrial fibrillation. It's clear, then you cardiovert the patient and you compare. Here is less, it's a little bit difficult. Do you have any recommendation, any additional thing that you may consider to evaluate symptoms in this kind of patients?
Yes. In fact, it's probably too narrow to only look for, do you have palpitations, yes or no, especially if we think that one of the follow-up could be the deterioration of ejection fraction. So palpitation is not the symptoms we are searching for. So heart failure signs should probably be an important additional question. And there are some studies also investigating on fatigue symptoms, so not palpitations, but fatigue, and that was also connected to higher BNP levels. So it might be interesting to investigate on BNP levels in these patients and asking other questions than only do you feel palpitations.
I completely agree. We often underestimate the symptom burden in our patients, and it's important to really seek it out, true symptomatology. I think a person who's diving probably really was truly asymptomatic, because that's definitely a form of a stress test, going under all those feet under the ocean. So I want to ask about amiodarone use in particular. I feel at my institution, perhaps we have a reflex to go to amiodarone to suppress the PVC burden, and seeing that in asymptomatic patients, it's a class 3 recommendation. What about in symptomatic patients with LV dysfunction? Like, can you walk me through amiodarone use as a definite no in every scenario?
Yeah, well, we know amiodarone is effective in a lot of arrhythmias, and we are happy to use it in the right indications. But here we are often talking about young patients, and the toxicity, especially over longer time, is not negligible. So I would really, talk more about this really being a class 3 indication. Still, of course, in patients with a reduced ejection fraction, it might be an option if you don't have any other options to take. But catheter ablation, and we will talk about this in the next presentation. Catheter ablation is something where you can really get rid of the PVCs and spare toxic drugs. I mean, I don't want to talk too much about toxicity in amiodarone. It's an important drug, but we have better than that.
Yeah, very good. Damiano, maybe you have you may comment on this aspect and how to evaluate these patients and potential drugs.
Yeah. Yes, it was a beautiful case, very educational, and I agree about the fact that you need to base your intention to ablate some patient, not only basing your feeling on fatigue, and we need something strong, like, I don't know, especially in asymptomatic young patient with a burden between 10 and 20% BNP value exercise test. I prefer cardiopulmonary exercise test that can objectively tell you which is the true functional class. I'm a clinic, I'm not interventional, so I often use drugs to treat my PVC. And I am wondering about the possibility to investigate this PVC during an exercise stress test. Sometimes some RVOT PVC are sympathetic drive, with a sympathetic drive. So if you, Dunker, Even in case the PVC, you see the PVC worsening during an exercise test, don't you try beta blocker in a middle-aged patient, not in a 30 years old, but in a 50, 55 years old.
Yeah, well,
just beta blocker, not any other.
To think about the individual patient. This one was a very special and sportive patient. If you have other patients, of course, you need to individualize your treatment. But again, there is no recommendation in the guidelines for asymptomatic patients with a normal ejection fraction for these drugs. This is something we need to keep in mind. And of course, we can treat our patients outside the guidelines, and we do this in other cases too. But remember this when choosing these drugs. On the other hand, we see patients that have an increased burden during exercise, showing us that this apparently is adrenergic, adrenergically driven. And of course, this is something that is very nice to treat with beta blockers. But in a 30-year-old patient, I would not prefer a beta blocker.
Yeah, I completely agree. On a 30-year-old,
beta blockers, they don't
try to ablate.
Like diving with beta blockers, etc. So yeah, this needs an individualized approach for sure.
Yeah, I fully agree with your comment. In fact, I was involved in this discussion during the guidelines, and I was in part of this section in particular. And the reason for not recommending drugs in asymptomatic patients with a normal ejection fraction, as you were mentioning, David, is that you treat patients to treat symptoms. That is not the case, or to improve prognosis. And in a patient with a normal ejection fraction, this is not the case. And if you plan to use something, it should be something with, that is effective, like ablation, and not associated with side effects. And as David has mentioned, especially in young patients, this may induce decrease of functional class, even problems, sexual problems, and so on. So.
Can I just ask a question for all of the heart failure community out there? What do you quote for the risks for a PVC ablation procedure?
Yeah, well, especially, and this is highlighted in the guidelines too, especially for right ventricular outflow tract ablation. This is very low risk. Of course, not zero, but low risk. And the aim of this procedure is to eliminate the PVCs. And this is very successful, with a success rate of higher than 90%. So this is very, very clear, straight, and safe. And then it's much better than treating a young patient over decades with drugs. And that's the reason why probably Jose chose to have this recommendation in the guidelines. And this is really a mechanistic approach that I fully support.
There is another important question that come to my mind when dealing with these patients. That is frequently the question is whether this is truly idiopathic or if there is an underlying cardiomyopathy. Because there are some morphologies, like the one that you presented, it was quite straightforward. You may comment on that. But is there any other thing that you may consider before ordering an MRI, or you will always ask for MRI in such a patient?
Well, that's an important question, because sometimes PVCs can also be the first symptoms to note when there is an underlying disease. And echo is not always sufficient to detect this early. On the other hand, we, at least in Germany, we don't have the infrastructure to get every patient with PVCs into an MRI. So it will not happen to have every patient with PVCs in this diagnostic assessment arm. But yeah, if the case is so clear, young patient, right morphology, and maybe you saw the rest of the ECG. Don't look only at the PVC, also look at the normal QRS complex. If this is completely normal without any interesting aspects, deflections, T negativation, etc., then I think this is really it's really valid to call it idiopathic. You can also look at the Holter, look for NSVTs. Usually in idiopathic PVCs, there are not a lot of NSVT runs, whereas in structural heart disease, you see maybe more than one morphology of PVCs and also more NSVT runs. And this can drive the decision, and when in doubt, you should take an MRI too.
Okay, thank you very much. Very clear, I think very useful. So let's move to the second case that is going to be presented by Andreu Porta from Barcelona University Hospital. Andreu.
Good morning, everyone. I'm very happy to present at this interesting course, and I hope I can share with you two cases that I think are very instructive from what we can get with ablation of BPV. So reduced LV function with PVCs, is it a cause or a consequence? That's the title of my talk. So the case number one is a patient who's 67, non-smoker. He's an active male. He's a BMI of 30, and at the age of 47, so 20 years ago, had an inferior lateral MI that was medically treated. Now, this led to an LV function of 40%, was on optimized medical treatment with dapagliflozin, bisoprolol at the highest dose he could tolerate, Entresto, and atorvastatin. And he had no symptoms and had an NYHA status of 1. You can see here that he presents to the outpatient clinic with his baseline QRS that shows normal, his baseline ECG that shows a prolonged PR interval and also a prolonged QRS morphology with a left bundle branch morphology, fragmented QRS of 180 milliseconds. And this is in bigeminy with a BPV that has an origin that probably is the inferior wall. You see a right bundle branch block morphology, a superior axis, and positive in AVL and D1. So clearly from the inferior wall of the left ventricle and probably more septal than lateral. We performed an LGE. We found a transmural inferior MI with some septal extension, and on the Holter ECG, we have a 33% burden of monomorphic BPVs. So we take the patient to the lab, and you see here how we look for this early origin. You have on the first bit is the intrinsic QRS, and the following bit has this BPV morphology. We've chased 3 different morphologies during the EP study, and we were successful in ablating those 3 morphologies. They were all having the same axis and a similar transition, but they had some subtle differences indicating different exit sites that we had to chase. So we had a very acute, very successful reduction in the EP lab. There were still some occasional BPVs with a different morphology that was not ablated. And then when he came back for the follow-up at 3 months, we obtained this ECG that shows his baseline QRS, still very broad, but also 1 BPV that has a different, completely different axis as compared to what we ablated before. And luckily, this led to only a 1% burden in the Holter monitor. But unfortunately, this patient had still the same left ventricular function after the successful BPV ablation. So in this case, ablation did not lead to a significant improvement to the LV function. And we'll talk about those prognostic factors and those outcome-related factors later on. Now, case number 2 is a different situation. The patient is 57, has a BMI of 32. He's very active, a lot of traveling, is a businessman, traveling all over the world. He's got type 2 diabetes. And in 2022, after a few months of feeling some lightheadedness and chest discomfort, finally somebody obtained an ECG. In this ECG, there were BPVs, and then he was studied with a Holter monitor that showed a 35% burden and an LV function of 40%. And he was started on guideline-directed medical therapy for heart failure with reduced LV function. And unfortunately, the LV function was still 40%, and there was no BPV burden reduction. He was severely symptomatic with chest discomfort, NYHA status 2 during the BPVs, and came for evaluation. We obtained this ECG. You see the baseline QRS morphology is normal. His intrinsic rhythm shows a bimodal P wave, which is interesting, indicating some atrial substrate as well, and a QRS morphology that is very narrow. And you see the BPVs that have a left bundle branch block morphology, an inferior axis, and negative in lead 1 and AVL at that time of the ECG. Okay, so we took the patient, before we move on to the ablation, just a brief reminder of the ECG clues, telling us if it's an outflow tract BPV from the right side or from the left side, which is important in terms of defining the risk of this patient. Also remember that in terms of defining the risk of the patient, the LGE pattern for this patient was 0. So there's no LGE on the MRI. And the dimensions of the ventricle were a bit dilated. So the differential diagnosis was dilated cardiomyopathy or BPV-induced tachycardiomyopathy. We move on to bring the patient to the lab. And you see here how the imaging helps us understand where the substrate is coming. We have an AP view. We have the catheter in the right ventricular outflow tract. We obtain an early area you see in red, but also in front of it, you see the distal coronary sinus. We just now remove the distal coronary sinus so we can see the septal side of the right ventricular outflow tract. And in this patient, we had to perform both ablation from the distal coronary sinus and also from the right ventricular outflow tract to be able to suppress those BPVs. So it was probably a BPV that was arising from the left ventricular summit, which is a challenging scenario most of the times. Luckily, the patient remained symptom-free, and this is the ECG during a follow-up with narrow QRS and no BPVs whatsoever. And in the Holter monitor, there was less than 1% BPV burden, and the left ventricular function was completely normal during follow-up with an LVF of 56% and a global longitudinal strain of 11%. So the most likely diagnosis was BPV that worsened a dilated cardiomyopathy, because you can see here that the ventricle, even after ablation and normalization of the LV function, was still mildly dilated. Let's look now at some of the evidence about the impact that successful ablation can have in patients with this type of poor LV function and high BPV burden. You see here that if you're able to achieve a PVC reduction of more than 18% with your ablation, then the likelihood of you experiencing heart endpoints like a cardiac mortality, transplant, or hospitalization for heart failure are improved. Another factor that we need to take into account is the baseline QRS morphology. And also David Dunker showed some nice slide about that, but this is about a different topic. You see here that the baseline QRS morphology indicates that you are unlikely to improve the LV function even if you have a successful ablation. If the BPV, if the narrow QRS, if the intrinsic QRS, has a width of more than 130 milliseconds, and remember our first patient had 180 milliseconds, even when we had a successful ablation, we could not improve the left ventricular function. So in summary, the high burden BPVs and LV dysfunction need treatment. There is a possible effect in heart endpoints, especially if the baseline intrinsic QRS is narrow. If the LV shows no late gadolinium enhancement, there are studies that show that as well. And if the BPV burden reduction is more than 18%, we can be quite happy that this will lead to better outcomes. And sometimes the diagnosis of a cardiomyopathy can only be made after treating the ventricular premature beats. And with that, I thank you for your attention, and I thank the team that works with me every day.
Wonderful. Thank you, Andrew, for that great presentation. And I have to say, you electrophysiologists have the most wonderful pictures and images for sure. So it was a great presentation. Let me ask you, you went over the location of the PVCs, but for us heart function cardiologists out there, does the location of the PVCs matter? And can you go over it really slowly and simply for me as well, how I tell the difference between them?
Yeah, this is a very relevant question because when we talk to the patient, and as Dr. Dunker said before, we need to make very clear what are the risks. And if we are suspecting a left ventricular outflow tract origin, that means that the patient will have a right bundle branch morphology, inferior axis, but a very early transition. Let's say that the R wave becomes very high in V1 or V2. We know 100% that we will have to go probably and map the aortic route. So this adds a layer of complexity to this population. But on the contrary, if we are dealing with right ventricular outflow tract BPV, so inferior axis, left bundle branch morphology, and also a transition, so an R wave that only becomes bigger than the S wave after, let's say, V3, V4, then we are very likely to face an area that will be easy to reach with our catheters. This is for the outflow tracts. Now, every other morphology, superior axis, narrow QRS pointing to the fascicle, structural heart disease, or wide QRS and superior axis and right bundle branch block tells us that probably this is going to be a much more tricky ablation, pointing to the base of the papillary muscle, or maybe if it's narrow and right bundle branch morphology, it will be in the fascicle. So this, in order to stratify the patient and the risk of the procedure where we are heading to, is very critical for us.
Let me just ask one more quick question and follow up. One of the go-to considerations for heart failure cardiologists, we look at electrolytes actually. And is there any role in maintaining a potassium over 4.5 in these patients or putting them on magnesium supplements? I seem to see that a lot in practice with patients with PVC cardiomyopathy.
So we use that in patients that come to the ICU with runs of the VT, idiopathic VT, or for any runs of VT, and supplements of magnesium in that setting are known to help. They are also known to help in patients with long QT that have frequent BPVs, but the role in long-term control of BPVs is unknown, at least to me.
Thank you.
Damiano, I don't know if you may comment or you have any question. Well, and I would like also to take the opportunity to encourage the audience to address questions through the chat. But in the meantime, Damiano, I don't know if you may have any consideration about these particular cases.
Yes, Porta, congrats. You told us about the first case. A patient was completely asymptomatic, and after the procedure, the ejection fraction did not improve. So again, from a clinic viewpoint, but it might be possible that this patient received an advantage in, I don't know, in peak VO2, drop BNP value, that are marker of prognosis. So it is. I know that you are an electrophysiologist, so you need to burn. But from a clinic viewpoint, I think that it could be better also for you if a patient did not improve ejection fraction and you see that his capacity, his exercise capacity, his peak VO2, his BNP drop. Why don't you decide also basing on a clinical laboratoristic marker different from fatigue, palpitation, NIA class?
Absolutely. You're absolutely right. And now looking back at this patient, we may consider that the procedure was an added risk for the patient and it was futile for him. So one thing that we consider very often in this population is that he is borderline for indication of CRT ICD. And if we can avoid that by having an improved LV function, even if it's only like 3 points in the LV function as looking at the MRI, or maybe 5 points in the LV function by MRI, then we may be very happy, even if the patient is completely well before the ablation. So, and one other topic is that if we put an ICD with CRT in this patient, he may end up having very low biventricular pacing due to the BPVs. So we may end up having to go down the same road to have the ablation done. So we took the decision without any BNP markers or some biomarkers that help us understand, because we had other clues in this patient and other reasons to go on this patient. But unfortunately, he remained completely the same, and probably he will need both the ICD and a CRT in the future.
Andrea, you discussed a very interesting aspect, that is that, and you presented two very different cases. One is clear, structural heart disease with concurrent PVCs, so probably not related to left ventricular dysfunctions, or not responsible of it, but the consequence of left ventricular dysfunction. And the second case, it was the opposite. It looks that PVCs were responsible of left ventricular dysfunction, right? But often in medicine, we're in gray zones. We don't have pure blacks and pure whites. Usually we have grays. And you may find patients, like the first one that you presented, with left ventricular dysfunction scar at the MRI, and then you have to take a decision whether you expect an improvement of ventricular function after ablation or not. Do you think that, for example, ECG morphology counts or other aspects about the PVCs, monomorphic, polymorphic? Mm-hmm. May you comment on this?
We like very much to have the information from the MRI, so the extension of the presence of LG itself and also the extension of it is a very good marker for successful change in the LV function. So in this patient, we could expect that the change was not going to be very significant, but in every patient with left ventricular dysfunction and or non-outflow tract BPVs, we obtain an MRI. Also, a CT scan is very useful for procedural planning, just in case we need to ablate from the cusps to make sure that we are not very close to one of the coronary arteries. So for us, imaging is a very important tool. And now the other topics are the ones that were highlighted by David Dunker. One of them is the QRS, the baseline QRS morphology. Also, the QRS morphology of the BPVs showing a very broad and epicardial likely origin are more responsible for dysynchrony and dysfunction than the narrow BPVs. And also the coupling interval and the fact that there are runs of non-sustained VT also point to a more advanced subset that will be less likely to respond to ablation. One other important topic about the ablation or the EP study is to know the location of those BPVs, because sometimes if they are very close to the HIS, then you know that you're going to be treating them with drugs before trying to ablate that area because of the high risk that they have. So I think it has an additional role also in terms of location of the origin to direct the treatment of the patient.
I was commenting this because, for example, if you see PVCs that are coming from the infarction area, you may think that they are more a consequence rather than a cause. But if they are coming, like the one that you saw at the end, that is coming from a completely opposite area, then they are probably unrelated to the substrate and maybe the cause. So this is something that also you may consider. Maybe, David, you may comment also in other aspects.
Yeah, maybe one important point, because we discussed, in my case, we discussed the low risk for RVOT and idiopathic PVCs. Balancing this risk is not always easy in patients with additional comorbidities, not only low ejection fraction, but we saw in Andrea's case, we saw type 2 diabetes, obesity, etc. So if we have these patients entering a procedure that sometimes lasts 2 hours, sometimes 4 hours, especially if it gets complex like in Andrea's case, this is something that we need to take into account. In addition, it's not only the location, it's also the complexity of not only the procedure, but also the patient. And there we need to consider ablation first or medication first in another way than in the young asymptomatic patients without comorbidities. Maybe, Andrea, you showed 2 cases. One was successful, one failed in terms of the procedure, and still I don't know if you would have done it differently now afterwards, knowing that it was not successful. But how do you decide on that?
Yeah, that's a very good point. So I would call both of them successful. Maybe I'm too optimistic, but they are successful in terms of burden reduction. So the burden reduction went very low. Now, completely successful for the first patient, no, but I was not expecting that the LV function would go to 55. I was expecting that it will not drop over time, and that we can skip the ICD CRT for this patient as long as he stays with NYHA class 1 and LV function over 40%. So that's, in my view, it's almost like a successful story. Then the second patient, to call it completely successful, I would ask you guys, the audience, to vote who would stop the heart failure medications in this patient. Are we calling this a completely different, completely PVC-induced cardiomyopathy, or is it who would be willing to stop the medications for heart failure in this patient? That's a tricky question that I'm facing.
Yeah, and I think we'll pull that forward for the next discussion as well, because I'm not sure there's a clear answer for that. I'm very interested in this. I'm thinking probably not, but we'll discuss it more. We're going to move on to our next presentation. Perfect. Now. Francesco Rafael Spera will be giving us a bit of a lecture on PVCs and the failing heart, desynchrony, dysfunction, and decisions. So take it away, Francesco.
Okay, good morning, everyone, and thank you for the opportunity to present this lecture. I will try to summarize what I've been discussing in this session. So PVC are often considered benign disease. However, it's not always the case. In patients with a significant PVC burden, generally above 10%, we know that the prevalence of PVC-induced cardiomyopathy is around 7%. And moreover, an higher PVC burden is associated not only with left ventricular dysfunction, but also with increased mortality and higher risk of stroke. It's important to clarify a key concept. As I mentioned in the previous presentation, when we talk about PVC and cardiomyopathy, we are actually dealing with two different clinical scenarios. On one end, we have PVC-induced cardiomyopathy, where frequent PVC are the primary cause of left ventricular dysfunction. On the other hand, we have cardiomyopathy with secondary PVC, where the heart is already diseased, and PVC are simply manifestation of abnormal myocardium. Distinguishing between these two conditions is essential because it directly impacts both prognosis and treatment. We can use several clinical clues to help differentiate between these two scenarios. First, echocardiography. In PVC-induced cardiomyopathy, left ventricular dysfunction is often global and mild to moderate. without major structural abnormalities, in contrast with the primary cardiomyopathy. Second, cardiac magnetic resonance is typically normal in PVC-induced cardiomyopathy and show minimal or no late gadolinium enhancement. Third, PVC burden, typically above 10-15%, supports a potential causal role in PVC in PVC-induced cardiomyopathy. And finally, the PVC pattern and the morphology. In PVC-induced cardiomyopathy, PVC are often monomorphic, arising from a single focus, frequently from outflow tract and epicardial region, in contrast with a polymorphic pattern that is more suggestive of a diseased myocardium. One of the most important aspects of PVC-induced cardiomyopathy is that it's often reversible. And as we see, this is a list of principal studies that investigate the role of catheter ablation in patients with impaired left ventricular ejection fraction and PVC burden over 20%. And we see that after effective suppression of PVC, left ventricular ejection fraction can improve significantly from approximately 37% to 51%, with an average increase of about 15% point. This is clearly highlights the importance of early recognition and treatment. Another key question in our clinical practice is what PVC burden should raise concern, and several studies show that ejection fraction gradually reduce when the PVC burden increase over 10%. But a cutoff of 24% was proposed in a study as the best value of PVC that predict with a sensitivity and specificity of 80% the risk to develop LV dysfunction. Other factors are also important, especially the QRS duration, as we mentioned before. A wider QRS reflects greater ventricular dyssynchrony, and this is associated with a higher risk to develop cardiomyopathy. And a cutoff of 153 milliseconds is the best predictor of this risk. Additionally, factors include male sex, the asymptomatic status, because of the delay in the first medical contact, and epicardial location due to greater ventricular dyssynchrony compared to PVC arising from outflow tract. And in our clinical practice, a tool, a score, has been proposed to help us to predict this non-outflow tract PVC. Burden of PVC reflecting the arrhythmia load and dyssynchrony, with the 3 point if the burden is more than 20%, and 2 point if the burden is between 10 or 20%. Coupling interval, as we mentioned, which influence ventricular filling and mechanical efficiency of the left ventricle. Longer is the coupling interval, more than 500 milliseconds, and more there will be an atrial contraction that take place against a closed atrioventricular valve during the PVC. And the presence of non-sustainability is also important with the 4 point. But before to discuss about PVC suppression, we should not forget the underlying pathophysiology with tissue, myocyte, and the electrical remodeling. From a mechanistic perspective, PVC promotes cardiomyopathy through intraventricular effects such as LV dyssynchrony, increased extrasystolic pressure, and through extraventricular effects like AV dissociation and autonomic dysfunction, with an increased sympathetic and vagal activity. Together, these mechanisms create a vicious cycle that may ultimately lead to heart failure. So to conclude, I would like to leave you with a few messages. First, not all the PVC are the same. It's essential to distinguish whether PVC are the cause of the cardiomyopathy or simply its consequence. High PVC burden, especially about 20%, should prompt consideration of treatment rather than simple observation. And morphology also matters, as a center PVC pattern are more strongly associated with PVC-induced cardiomyopathy. Thank you for your attention.
Thank you, Francesco, for this nice overview. I think that you have provided us with many factors associated with non-reversible ventricular dysfunction after PVC removal. But if you will need to give just 3, because, for example, if you are sitting in the outpatient clinic and you receive a patient with a high burden of PVCs and left ventricular dysfunction, you need to quickly decide, and you're not an EP specialist, and you need to decide whether this is a typical tachycardiomyopathy patient or not, and what would be your 3 favorite or the 3 main predictors that you will choose?
I will choose, of course, according to the morphology, and I will use also some clues from echocardiography. We know that also we can study with the strain the synchrony of the left ventricle, and sometimes also to understand the time when it's important to ablate this kind of PVC. The left ventricular desynchrony is one of the first aspects that we could evaluate on echocardiography before the left ventricular dysfunction, and also the presence or not of the scar on cardiac magnetic resonance.
Okay, and what will be your favorite 3, David?
My 3? I think I showed it. It's always morphology, burden, and ejection fraction. I look for these 3, and I like considering the other ones, but these are my 3.
What about others?
Well, those all sound great and very straightforward for those of us who aren't doing the actual procedures. I do want to get back to that question, though, about do you reduce the guideline-directed medical therapy? Do you withdraw therapy in patients who've recovered their ejection fraction? We know from the TREAD-HF trial, when patients had an improved ejection fraction, then had randomized withdrawal, that their ejection fraction, in fact, did decline. So in general, within the heart failure community, there's a practice to maintain these disease-modifying therapies long-term if they're being tolerated. What about something like in PVC-induced cardiomyopathy? Do we have any data to support withdrawal of medications at this point?
Yeah, in fact, we see this in other entities that withdrawing the heart failure drugs after deterioration of ejection fraction is not a good idea in most of the times. As we've discussed previously, the PVC idea is a mechanistic approach, and we always think, okay, if I eliminate the PVCs, I eliminate the problem, and then it's done, we can withdraw everything, but we need to take into account that there are patients with PVCs and no reaction in ejection fraction, and there are PVCs leading to a reduction. So there must be another point in this progression of a disease. It's not only the PVC. So in fact, probably it is wise to continue the heart failure medication and to observe the patient and to decide at a later stage if this is for the rest of the life or if we can withdraw it at any time. But still, reduction in ejection fraction only because of PVCs means something different than only PVC.
Yeah, I fully agree. I think that we have seen this in other subsets, atrial fibrillation, for example, that after tachycardiomyopathy, you treat atrial fibrillation, you get rid of atrial fibrillation, and then stopping ventricular function recovers, but then you stop drugs, and it's not a good idea. However, it's true that it's a different scenario because patients with atrial fibrillation means that they have something else. In a patient with PVCs, we still don't know, especially the typical patient that for me is not associated with structural heart disease, like is the one that with typical right ventricular outflow tract PVCs, morphology, those with single morphology rather than multifocal, I think that these patients in general are not associated with no underlying heart disease. But it's true that at present we don't know, so probably it makes sense to at least wait for a while before taking that decision.
Damiano, we're getting close to the end of our session. Do you have a quick question for Francesco?
Yes, just a remark about the therapy, to maintain or not the therapy. I wonder about a patient who fully recovered his ejection fraction, since you love ejection fraction, but also the beta blocker you maintain, because I understand and I agree about the MRA, the neprilysin and Entresto for a recovery, fully recovered, but a beta blocker that in an HF path is not so, is questionable. Do you think that it is good to maintain also the beta blocker in a cardiomyopathy PVC induced? Because there is a problem of chronotropic incompetence, they are younger. So
this is a really good question, but there are some studies we have shown that the PVC, one of the mechanisms of the PVC-induced cardiomyopathy is also increased sympathetic activity. So there is some study, also animal study, they show that even after the PVC suppression, the sympathetic tone persists. And this is could lead during the follow-up to some VT, that is life-threatening arrhythmia. So I think that could be a good idea to maintain in this kind of patient beta blocker to contrast the sympathetic activity.
Okay.
Great. Super. So I think we will move to our close and get some final thoughts here. Thank you so much for teaching me so much during the session. So my big learning points are PVC burden greater than 10% requires further investigation. PVC-induced cardiomyopathy is in fact reversible. And treating PVCs in HFrEF is very important to consider. I think differentiating between whether it's a primary or secondary cardiomyopathy, that becomes a little bit more challenging for me and requires the collaboration with our electrophysiology specialists. And then based on the presentation, there's still, I think, an important role for GDMT in those patients with HFrEF in particular. So thank you for teaching me about coupling intervals today, the ABCVT score, and the PVC RVOT ablation procedure is relatively low risk. I think you're going to be seeing a lot more referrals happening because of this session. So with that, thank you to my co-chair and to all the speakers. Thank you to iHF for bringing our communities together. Hope you enjoyed the session.
Good morning, I'm Dr. Francesco Giafali from Sant'Andrea University Hospital in Rome, and it's an honor for me to present this clinical case entitled Stepwise Percutaneous Approach to Combined Valvular Heart Disease in a Patient with Heart Failure. We report the case of an 82-year-old man who was admitted to our cardiology unit for acute decompensated heart failure, his second hospitalization in the last 4 months. He was a former smoker, and his cardiovascular risk factors include arterial hypertension and type 2 diabetes mellitus. His past medical history was notable for a previous ischemic stroke without residual deficits, permanent atrial fibrillation, and permanent pacemaker implantation. He was on optimized guideline-directed medical therapy for heart failure, and laboratory tests showed mild anemia, stage 3 chronic kidney disease, and markedly elevated NT-proBNP levels.
invasive coronary angiography excluded obstructive coronary artery disease. Transthoracic echocardiography revealed global left ventricle hypokinesia with a reduced ejection fraction of 35%, as well as severe biatrial enlargement. Valve assessment demonstrated multiple severe valvular heart disease, including severe low-flow low-gradient aortic stenosis with a mean gradient of 20 mm of mercury and an aortic valve area of 0.7 square centimeters, and a severe secondary tricuspid regurgitation with an estimated systolic pulmonary artery pressure of 55 mm of mercury. Cardiac computed tomography was performed to confirm the diagnosis of low-flow low-gradient aortic stenosis and to plan the procedure, including vascular access assessment and prosthesis sizing. The aortic valve calcium score was approximately 2,200 Angstrom units, confirming the severity of the aortic stenosis. According to current ESC guidelines, the clinical case was discussed by the multidisciplinary team, and transcatheter aortic valve implantation was indicated due to the patient's surgical risk. TAVI was successfully performed with transfemoral access using a 29 mm navitor valve. Post-procedural transthoracic echocardiography showed normal transvalvular gradients, trivial paravalvular leak, and persistent severe tricuspid regurgitation. The patient was discharged on day 3 in NIA class 2 dyspnea, and a follow-up was scheduled after 45 days in order to reassess the severity of tricuspid regurgitation. At follow-up, the patient reported persistent dyspnea with clinical sign of right-sided heart failure. Transthoracic echocardiography showed a significant improvement in left ventricle ejection fraction, increasing from 35 to 50%, with normal TAVI function and trivial paravalvular leak. Right ventricle systolic function was preserved. However, severe secondary atrial functional tricuspid regurgitation persists. According to the T-score, the predicted in-hospital mortality for isolated tricuspid valve surgery was intermediate, approximately 80%. Therefore, transesophageal echocardiography was performed for detailed anatomical assessment. This revealed a 4-leaflet tricuspid valve morphology, a central regurgitant jet predominantly between the septal and the anterior leaflets, with a coaptation gap of 6 to 7 mm. The pacemaker lead was positioned at the posterior commissure, and it did not significantly contribute to the etiology of the tricuspid regurgitation. The glide score predicted a favorable procedural outcome of approximately 60 to 70%, and their team confirmed the indication for transcatheter edge-to-edge tricuspid repair. The procedure was successfully performed with the implantation of one triclip XTW device between the anterior and the septal leaflets, achieving procedural success without complication. Pre-discharge echocardiography showed the stable clip position with a mild residual tricuspid regurgitation and a mean gradient of 1 to 2 mm of mercury. At 30-day follow-up, the patient was asymptomatic at rest, with significant improvement in dyspnea and no sign of right-sided congestion. In conclusion, acute decompensated heart failure is often driven by valvular heart disease, particularly in elderly patients with multiple comorbidities. Assessing the severity of valvular lesion in this setting may be challenging due to dynamic changes in loading condition and the coexistence of multiple valve disease. Evidence guiding the management in these patients remains limited. Therefore, therapeutic strategies should be individualized and based on multidisciplinary team evaluation. In this selected high-risk patient, intervention is indicated in presence of symptoms or ventricular dysfunction, starting with the most distal valve suitable for percutaneous treatment. Thank you for the attention.
Ladies and gentlemen, we have officially reached the finish line of this first iHF annual course. But however, it does not feel like the ending of something. It feels more like the beginning of something much bigger. We have had, as far as to this morning, more than 3,700 views and clicks across all platforms, confirming that we have chosen the adequate format to deliver the educational content. And the statistics also demonstrate that we are approaching and reaching a truly global and transdisciplinary community. People were watching us from Europe, from Asia, from America, Africa, and from the Middle East, so from all over the globe. And they had a very diverse backgrounds. We had general cardiologists, interventional cardiologists, cardiac surgeons, electrophysiologists, cardiovascular imagers, and heart failure specialists watching us. So we are really transdisciplinary, and this reflects who the people are who are treating patients with heart failure. And as we look ahead, let's celebrate the people who made all this possible.
We wish to thank all our faculty for the time, commitment, and the great insight, and I believe we have appreciated the quality and the level of our sessions. But also we want to also thank all the selected abstract presenters that presented the multidisciplinary cases that we've all enjoyed. And this meeting wouldn't have been possible without the help of our partners that we wish to thank.
Let's just make one step back and quickly review what we've gone through these 2-day meetings. These are the highlights of day one. We started with this first session on acute coronary syndrome with cardiogenic shock to conclude that the implementation of regional cardiogenic shock network is essential to disseminate best practice and ensure best outcomes. We continue then with patients with aortic stenosis awaiting TAVI, and the group agreed that optimal management in severe aortic stenosis requires integration of valve interventions, comorbidity management, and as needed heart failure treatment. That was not enough. We went on with the advances in the management of heart failure, where we learned the direct HF approach to personalized timing of referral for ICD or CRT according to the patient profile, ending day one with another important session of mitral regurgitation, where the consensus in the group was that in patients with heart failure with reduced ejection fraction, with secondary mitral regurgitation, early GDMT optimization can be enabled by M-TEER, warranting improved clinical outcomes.
And for day two, we have a tremendous program. And I think that the keyword for this session today was the connection between different specialty to treat heart failure patients. And we started with aortic stenosis and patients with FREF. And in fact, this session did show that in patients with FREF and severe aortic stenosis, they will benefit the most from integrated transdisciplinary care warranting optimized pharmacological treatment and evidence-based interventions. So TAVI is not only the only solution for patients with aortic stenosis. Then we have a very interesting session about patients still is FREF, about the device, and we have a clinical case showing that the fundamental role of transdisciplinary decision making in the selection of a patient in the need of cardiac implantable electronic device. And you appreciate that sometimes we disagree a little bit on the management of this patient, and this is the value of this session. The third one was about decongestion management, and in fact bringing intelligence with the reprieve therapy to achieve rapid and effective decongestion. Then we have a final session about PVC, and I think that after this session you will not see PVC as you did before, because we discuss about how to distinguish PVC-induced cardiomyopathy and cardiomyopathy leading to PVC. So look at the morphology of the PVC, and probably this can help you to make a decision making.
Thank you, Christophe. All the scientific content of all those sessions will be available online for all of you. It's easy to connect. You have here the website, and it's there to stay forever. Then really, it's going to be your site. Use it as much as you can. Please share this link with your fellows, your colleagues, your medical students, because as you just heard, those 8 sessions brought so many educations to all of us, and really you should benefit from it. Now, this is not the end. As what Sabine said earlier, it's the end of the scientific sessions. However, there are many, many things happening in the next month. You saw the online event, which I think we would all agree that it was a big success, and we learned all so much. In the following weeks, we will have a webinar. I will show you in a minute the next webinar that will be also online here from the studio. And indeed, all year long, you will have on-site course and you will have educations, clinical cases, and we will tell you more about the on-site course in the next weeks. Please, 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 if you liked all the sessions we had here in Paris, please connect to the next webinar. You can use the chat. You can ask all your questions to the top experts. This is the 19th of June, and it's HFrEF and chronic coronary syndromes from guided directed medical therapy, GDMT, to optimal revascularization strategy and return. Then again, you understood that the website is yours. All the educational material are also yours. And if you have some cases you would like to share with us, please send them to us, and we'll be happy to present them in our web. Then you see that this website is really interactive, and we count on you to make it even more lively. Thank you for connecting during these 2 beautiful days, and we hope to see you soon in our activities.
Thank you.